Good morning. The
Morning.
meeting will now come to order. Please note that this meeting is being recorded. And usually we start with a roll call, but we have several new members of the advisory committee. And so we're actually going to start by swearing in the new members of the advisory committee. So I'll ask Sean and Nancy and Mike, who are here in person, and Katina, who is online. And our third person is Magdalena, who I don't know if she's online. If so, please turn on your camera and let us know. So all board returning advisory committee members, if you'd sign your oath and turn them into the team. But for new members, we're going to get to do the whole shebang and do the swearing in. So I'll invite you, Mike and Nancy and Sean, to come on up here if you would. And Katina, you can follow along. That would be great. And after we do the swearing in, we will do the roll call and then do the rest of the meeting. So you will come on over, Mike. Thank you so much and welcome to the Healthcare Affordability Advisory Committee. So and then say your name. Go ahead.
Hi, Katina Murray.
You are exactly repeating after me each yourselves. Go ahead. 1, 2, 3. I do solemnly swear or affirm
Do solemnly swear or affirm
that I will support and defend the Constitution of the United States
that I will support and defend the Constitution of the United States
and the Constitution of the State of California
and the Constitution of the State of California
against all enemies, foreign and domestic,
against all enemies, foreign and domestic,
that I will bear true faith and allegiance
that I will bear true faith and allegiance
to the Constitution of the United States
to the Constitution of the United States
and the Constitution of the State of California,
and the Constitution of the State of California,
that I take this obligation freely
that I take this obligation freely
without any mental reservation or purpose of evasion,
without any mental reservation or purpose of evasion,
and that I will well and faithfully discharge
and that I will well and faithfully discharge
the duties upon which I am about to enter.
the duties upon which I am about to enter.
Thank you very much. Thank you, Nancy. Thank you, Sean. Thank you, Mike. Thank you very much, Dr. Murray. Okay, and with that, we are able to go for the roll call. Bless you.
Good morning. All right, for roll call, please make sure that you speak into your mic and your mic is on. There's a red light at the base of the mic that just says that it's getting power. But when you press the button, you'll see a red band around the top of the mic, and that means that you've got a hot mic. Let's get started. Amanda McAllister Wallner. Andrew C.
Present.
Barry Arbuckle.
Present.
Carolyn Nava.
Present.
Christina Rodriguez.
Present.
David Joyner.
Present.
Hector Flores.
Here.
Iftikhar Hussain.
Present.
Thank you. Thank you. Janice O'Malley.
Present.
Joan Allen.
Present.
Cassie Maroney. Katie Bassler.
Present.
Katina Murray.
Present.
Ken Stewart.
Present.
Kieran Savage Sangwan. Magdalena Pruitt. Manan Shah. Michael Weiss.
Present.
Mike O'Day. Mike Rayborn.
Present.
Nancy Netherland.
Present.
Sarah Sorokin. Sean Kim.
Present.
Stephanie Klein. Stephen Shortell.
Present.
Sumana Reddy,
Present.
Suzanne Usage,
Present.
Tam Ma, and Travis Lakey. Thank you.
Thank you. And with that, we have a record of who is in attendance. And I'd like to also note that our attending board member is Rick Kronick, who is attending virtually today. He'll listen to the presentation and discussions and help convey your input to the Healthcare Advisory Board. And we'll move on to the agenda. We'll pull up the agenda slide. So after our executive updates, we will have a cost reducing strategy presentation from the LA General Medical Center's Safer at Home program, and we appreciate them being here. And then CJ and Vishal will discuss the non-supervisory organized labor adjustment data collection regulations. After lunch, Vishal and CJ will continue presenting on the spending target enforcement related to OCA's approach to spending target penalties. And then last, Heather Hoganson, Assistant Chief Counsel, will close out the meeting with a status update on the cost and market impact review program. So before moving to executive updates, we're going to let the new advisory committee members introduce themselves and give them an opportunity to talk a little bit about what drew them to apply to the Affordability Advisory Committee. So I will start. Dr. Murray, if you'd like to introduce yourself, your organization, and what led you to apply to be on this advisory committee.
Yes, thank you, and hello all. My name is Katina Murray. I am a family medicine physician by training. I'm currently at Keck Medicine of USC and am the vice chair for clinical affairs for the Department of Family Medicine. So primary care is near and dear to my heart. I have really been interested in the work of the committee around health spending targets, around accountability for Californians to have affordable care. I also serve as the Associate Chief Medical Officer for USC Medical Care Group, as well as am on the governing board of an ACO. So a lot of the work that you're doing really intersects with my interests, intersects with the things that I've done over the course of my career, and I'm just excited to be a part of all of the work that's surrounding affordability with healthcare. Thank you.
Sorry, Vishal. Thank you very much, Dr. Murray. Next, Nancy Netherland, if you'd introduce yourself, please.
Thank you. My name is Nancy Netherland. I'm with Family Voices of California. I also sit on a few different advisories, including the Medicaid Children's Health Advisory Panel and also the American Academy of Pediatrics Children and Youth with Special Health Care Needs National Advisory. And time again, affordability is a topic and an issue, especially for families who have children that live with disabling conditions, rare diseases, or special health needs. And then just looking at, I do a fair amount of policy work at the state level, and I think it's important to look at the balance of high quality and affordable and sustainable care. And I really wanted to be a part of the dialogue of how do we make care affordable for all families, all patients in California. Thank you.
Thank you very much. Sean.
Hello, everyone. Sean Kim from California Pharmacists Association, pharmacist by training, and wanted to provide some perspective of how pharmacy also intersects with all the healthcare cost, especially when we're talking about total healthcare cost in California. Pharmacy is access to the care points, as well as not just the dispensing lens, but also it is related to all the health systems and inpatients or clinics. So we'd love to provide those perspective and help for the Californians. Thank you.
Thank you very much, Sean. And Mike, if you'd introduce yourself, please.
Sure. Yeah. Mike Rayburn. I'm Assistant Director of Research with the California Nurses Association, National Nurses United. I was interested, in this body for a number of reasons. Like I spend a lot of time looking at healthcare data, especially data that's produced and sort of disseminated by HCI, so there's an element of data production through that OCA's involved in, which I'm really excited about. But more importantly, the affordability of healthcare, especially as it relates to hospital charges and pricing, I think and drug pricing is really important to address. And I've spent a lot of time, researching those issues. But there's this angle of, ensuring affordability while protecting essential services and, workforce issues, especially obviously for me, nurses in particular, but making sure that patient care and safe staffing practices are protected as we look to hold costs down is a very important angle for me and for my organization. Very happy to be here.
Terrific. Thank you so much. We appreciate each of you, and thank you for your service to the advisory committee. We will move on to executive updates. And I want to give us a few updates related to behavioral health workforce and HCI's work. So for new members, I usually start with a few department-wide executive updates and then turn it to Vishal to talk about more OCA-focused updates. So we are required every 5 years to develop our WET plan, Workforce Education and Training Council. So under the Behavioral Health Services Act, 3% of the funding that comes in from that millionaire tax comes to HCI to develop the behavioral health workforce, which of course is of interest and necessary for a high-value healthcare system. So we spent 10 months listening to stakeholders and developing our WET plan, which was published and approved a few weeks ago. And we'll start receiving funding now that the new fiscal year has started, really focusing on providing services to folks with the highest healthcare needs. And we heard a lot from stakeholders that you can come out of social work school or come out with a psychology degree and not really have the specific training to work with folks who have co-occurring conditions, experiencing homelessness, recently incarcerated, substance use disorder. So really trying to focus on the needs of our highest acuity behavioral health patients. So we're excited to start that work. Also related to behavioral health, Mathematica recently published a report on California's $4.7 billion Children and Youth Behavioral Health Initiative. 5 years ago, Governor Newsom launched that initiative to really to recognizing the behavioral health crisis that children and youth are facing. And so HCI administered the behavioral health workforce components of that, including developing this new wellness coach role, and we now have almost 5,000 wellness coaches serving in schools and community-based organizations providing support to children and youth. And there are some great outcome statistics that we're seeing some improvements, lower suicide ideation, and improved outcomes for children and youth, which is very heartwarming. I know the HPD, the Healthcare Payments Data Program, is of interest to this group, so I'll just mention some of our new data briefs that were released in collaboration with OCA, and I think Vishal's going to talk a little bit more about these. HCI released the GLP-1 prescription for weight loss over time, looking at a 5-year period, and this presents prescription and cost information for GLP-1 use for weight loss by drug product in the commercial and Medi-Cal markets. So again, Vishal will talk more about that. And then we also released an insulin and metformin geographic access and mail order use study, which presents miles traveled to pharmacies and mail order use by county. So it looks like Sean's familiar with that. It being July 8th, we are 1 week into a new fiscal year in California, and so I won't go through all of the budget components related to HCI, but I will mention a few new components that I think will be of interest to this group. The budget included funding to support gender-affirming care in light of the federal government's assault on providers providing gender-affirming care. California is once again stepping up to the plate, and so there's funding for HCI to work to support the provider network and to provide a stabilization program and some funding for uncompensated care. There's also a new money to support distressed hospitals, so there's a new $90 million allocation to provide grants to hospitals in financial distress. The legislature has been very clear that they don't want to just keep giving out this money, but really try to better understand kind of the underlying causes. So they've asked us and provided funding to HCI to set up a new unit to evaluate hospitals' strategic importance to their communities, assist in planning for maintaining critical services in the event of hospitals' financial distress, and provide technical assistance to financially distressed hospitals. So that is a new body of work that we will get started on, and certainly recognize the importance of that. And then the last piece that I wanted to mention in the budget that we're very excited about is there's additional funding for CalRx to support development of lower cost epinephrine pens and tuberculosis drugs. So every year, and Vishal also oversees this work with our CalRx team, we do an analysis of target drugs looking at vulnerable populations impacted, high cost drugs, also look at how many folks are impacted. For TB drugs, for example, of course, it's a lower population, but we're seeing some drug scarcity issues. So we, in the budget, there's funding for HCI to work to develop a new entrant into the EpiPen market, and we hope to distribute these pens to schools statewide, as we're doing with albuterol. And then for tuberculosis drugs, CalRx will identify a supply partner and set up an ordering system, again, due to some failures in the drug market. And then last but not least, I want to mention on our California Rural Health Transformation Program. Very excited that a week ago we released our first RFA, our first request for application, and that is specifically for our accelerator partnerships. So we'll be releasing a series of RFAs this month, and for each we'll be publishing the application, publishing a grant guide, and doing a webinar and an FAQ. So please sign up for our RHT, Rural Health Transformation, alerts if you're interested in tracking this information. And with that, I'll turn it over to Vishal Pagani.
Thank you, Director. We have a few articles to share with the Advisory Committee today. The first is an article published in Health Affairs this month, which assessed the effects of private equity acquisitions of primary care practices on primary care physician practice patterns and patient care. So this was they took a look at patients in the traditional Medicare market. The study identified 225 private equity acquisitions during the period 2016 to 2022, and compared these practices with 1,125 matched cohorts across the 5 quarters before and the 5 quarters after the acquisition. The study used differences in design to examine differential changes in outcomes of interest between the PE acquired practices and control groups. The authors found that in private equity acquired practices compared to matched controls, at the physician level, the number of claims billed increased by 50.6 per physician, or about a little over 30%, as shown in the figure. Specifically, Medicare initial annual wellness visits increased by 21%. The number of patients seen per physician increased by 8 patients, or 11%. Medicare spending per physician for physicians billed by the PCP increased by a little around $850, or around 15%. At the patient level, patients received 11.1% more laboratory tests and 11.3% more preventative and screening services. In contrast, visits per patient decreased by 1.3%. And there were no significant changes to Medicare spending per patient per physician on services billed by PCPs. I'd also note that though these findings were statistically significant, some of the confidence intervals for the point estimates are quite wide, making the true effects of PE acquisition on these outcomes uncertain. There were no significant differences in patient complexity as measured by hierarchical condition category codes after acquisition, making increased patient complexity an unlikely driver of the observed differences. Next slide. Additional workforce analysis found that after PE acquisition, practices increased the total number of PCPs by 16.9%, and advanced practice providers by 40.1% compared to the controls. However, because many advanced practice providers bill under physician NPIs, the study could not determine the extent to which observed increases in service delivery in PE acquired practices may have been driven by greater reliance on advanced practice providers. Some of the limitations of the study are noted here. The study methodology, I'll just go over the first one. The study methodology, while designed to capture as many PE acquisitions as possible, may have missed some. It was also notable that 75% of the PE acquired practices were in the southern US and only 13% in the West. As I mentioned earlier, the data was also restricted to Medicare claims, so it does reduce the generalizability of findings to other populations. The authors concluded that private equity investments can increase the use of primary care services, including preventative services and laboratory tests, and the number of patients seen by primary care providers within the traditional Medicare program, potentially expanding access to primary care. The authors noted that while the observed increases in service intensity in the PE acquired practices may in part be due to greater reliance on advanced practice providers, another explanation could be introduction of productivity targets for providers, such as seeing more patients or providing additional services. Such productivity pressures could contribute to provider burnout. The authors also suggested that PE-backed practices may be positioning themselves to capitalize on fee-for-service payments, such as the Medicare annual wellness visits, which are reimbursed at higher rates than routine office visits. Evidence suggests that in Medicare Advantage-oriented primary care, PE firms enter joint ventures with insurers, which is associated with increased risk coding rather than utilization growth. Finally, the authors called for greater ownership transparency to accurately evaluate the scale of PE consolidation and its effects on delivery and equitable access. So I'll go on to our next article, which was published in the Journal of American Medical Association, or JAMA, in May. The authors propose a state-administered primary care common fund as a way to address fragmentation and underinvestment in primary care. The proposed fund would consolidate existing primary care spending from public and private sources and pay primary care practices directly outside of insurance, similar to how public utilities finance public goods such as electricity and water services. The common fund would function as a multi-payer financed state-run resource pool supported by contributions from both commercial and self-funded health plans, as well as transfers from Medicaid. Initial contributions into the fund would be set to match current primary care spending across states with the intention of increasing investments over time to align with the state's primary care investment goals and benchmarks. These increased funds would in part be used to ensure access to primary care for individuals without insurance. The authors go on to propose that each state have authority to determine how primary care practices are paid. This could be fee-for-service, prospective per member per month payments, or some combination, and to establish cost-sharing limits. Traditional insurance would remain unchanged for non-primary care services. They go on to note some limitations with the common fund approach. As with any public program, it could be vulnerable to state budget pressures because the common fund would be limited to primary care, wouldn't address challenges in other sectors. And although it would bolster primary care spending, it would not automatically address all primary care workforce challenges. So those areas would still need additional policy support. Next slide. So they go on to emphasize several factors they believe indicate that implementation of a primary care fund is feasible. So they, I won't read these all, but just to point out a few. They did focus on how it's compatible with existing payment systems. They note that a primary care common fund could operate alongside traditional insurance, ACOs, and other value-based payment models, minimizing system-wide disruption and lowering resistance from stakeholders. And then they also pointed that there is precedent for this for similar funding mechanisms in healthcare, such as state and federal health plan taxes, supporting Medicaid programs, and the Patient-Centered Outcomes Research Trust Fund. And I'll take us to our next article, which is from the Health Affairs Forefront. It's titled, States Are Exceeding Their Cost Growth Targets. What does it mean? The article emphasizes that while cost growth targets and transparency can reveal the sources of spending growth for the 8 states with targets, complementary policies are necessary to meaningfully bend the cost curve. They contend that the main drivers of high commercial market trend include commercial claims in hospital services and retail prescription drugs. Together, these areas account for the majority of per person commercial spending and have seen the greatest increases in growth, which they suggest make them a focal point for cost containment policy. The authors note that spending trends in these areas reflect the significant pricing power and limited regulatory constraints for hospitals and manufacturers, which transparency can elucidate but cannot alone address. For hospitals, studies point to provider market consolidation and a resulting weak insurer bargaining leverage as a contributor to price growth, alongside with strategic use of claim coding to maximize provider revenue. For pharmaceutical manufacturers, pricing power is reinforced by structural factors, including government-granted patents, which create time-limited monopolies, and the relative absence of any regulatory ceiling on launch prices. To constrain spending growth, a number of states, both with and without targets, are using their data to move toward hospital and pharmacy-focused approaches, especially in the commercial market. I won't go through each state, but a summary of approaches to constrain hospital growth include implementing price caps, price growth caps, reimbursement ceilings, and lowering targets for high-cost hospitals, and facility fee bans. Next slide. The article also goes on to discuss state pharmaceutical approaches to constrain spending growth. Colorado can apply an upper payment limit if a review board determines drugs are unaffordable, while Maryland is authorized to set upper payment limits for all purchaser and payer reimbursements of drugs, except where preempted by federal law. Minnesota, Oregon, and Washington have similar authority. In Connecticut, price increases for off-patent and generic or biosimilar drugs are capped at the rate of inflation. The authors note that that cost growth targets make healthcare costs visible, identify who's accountable, and build the case for more direct interventions. Among the authors' conclusions are that the above state initiatives represent a fundamental shift in how states exercise authority over healthcare markets, and that states with cost growth targets may need complementary strategies to rein in excess healthcare spending. So just a few more updates. So this was the article that the director mentioned. So HCI used data from the healthcare payments database from 2018 to 2023 for Medi-Cal and commercial payers. This brief examines GLP-1 scripts for weight loss over time and the total cost of these scripts by plan type per member. Key findings include GLP-1 utilization from 2018 to 2023 increased substantially for weight loss utilization in the state of California from 20,000 prescriptions to over 700,000 prescriptions. In the most recent year of available data, the total overall cost for GLP-1s for Medi-Cal and commercial plans was approximately $822 million. The statewide average yearly costs on a member basis receiving a GLP-1 prescription for weight loss was $5,329 in 2023. These costs varied by county, ranging from 3,051 in Lassen to 5,096 in Mendocino. With recent changes to coverage for weight loss utilization, prescription volume and cost trends are expected to change between Medi-Cal and commercial plans. We'll continue to track trends in this area and compare more years of data as it becomes available in the HPD. We're also aware of the direct-to-consumer sales channels for GLP-1s and the significant price reduction. So we'll be continuing to track these impacts in the future. Next, I'm providing an update on next steps for the equity adjustment, which we discussed at the June 2026 board meeting. As a reminder, our proposed recommendation was to not apply an equity adjustment to payers' performance against spending targets, which we presented to you all in April. Our proposed approach was to evaluate changes in social risk for payers through on the back end through the enforcement considerations process. After discussion with the board, the proposed next steps for the equity adjustment are to reassess the payer level equity adjustment suitability for improving health equity in at least 2 years. During that time, we'll monitor and assess new methodologies used by other programs and explore opportunities to conduct or emphasize the need for additional research on the relationship between equity, quality, and cost. Additionally, OCA will continue its work to assess whether and how to develop an equity adjustment for physician organizations and hospitals. We'll also conduct more literature research and engage expert consultants about an equity adjustment for these two provider types. And then taking us to the update on the quality adjustment recommendation. So this was also presented at a board meeting. For quality adjustment, our recommendation is to wait to apply a quality adjustment to the spending targets. We would like to note that this recommendation changed as we moved through the development process. In the April advisory committee meeting, we proposed not applying a quality adjustment to the spending targets. This revised recommendation applies to entities that deliver high-cost care not commensurate with improvements in quality, and entities that deliver low-cost, high-quality care. For the next steps, we will continue to monitor cost and quality data and reassess quality adjustment factors in at least 2 years, aligned with the timeline for reassessing the equity adjustment. And then we'll continue to monitor how the sibling departments such as DMHC are assessing and benchmarking quality performance. And then my last update, there's not a slide for this, but so one is about the primary care snapshot initiative, which we introduced at the January meeting. So the HCI primary care snapshot, it's a enterprise initiative here at the department that will report primary care data from both HCI and external data sources to create a shared understanding of the health of California's primary care sector and track progress towards equitable, high quality, and sustainable primary care for all Californians. In fall 2026, we will release the first primary care snapshot as a static report, including data from roughly 20 indicators across 5 domains. So these include investment, workforce, access, quality, and equity. The metrics selected for this first snapshot report were informed by HCI's multi-stakeholder primary care snapshot work group. We'll provide an overview of the snapshot report to the advisory committee after it's released in the fall. Looking forward in 2027 and annually thereafter, HCI plans to release the primary care snapshot as both a static report and an interactive dashboard. And then lastly, as we do at every public meeting, we'd like to remind the advisory committee and members of the public about our slide formatting key. So we note it with the blue area to indicate areas where we're seeking input from the advisory committee. And I'll now turn it back over to the facilitator.
All right, discussion and questions from advisory committee members. And for our new members, you can just raise your hand, and I try and capture the order that you raised your hands and call on everybody. So I'll start with Sumana, Stephen. Great. Go ahead, Sumana.
Thank you. Appreciated all of that information. And I wanted to speak specifically to the primary care as a public utility, the second article that you presented. This idea of a common fund or a unified payment is, something that's intriguing, very innovative, and we believe like really worthy of, this advisory committee looking at further, perhaps with a presentation, from the people who wrote that article. This idea of strengthening the viability of primary care to do what it does, the principle that access, longitudinal care, these are the things that have been so harmed by, particularly with my sort of working class population that goes on and off of insurance, high deductible insurance, Medi-Cal. And so if you have a common way to pay for that, you can ensure, even better primary care. I believe that will allow for better quality, cost savings overall for the population when you look at it as a statewide issue. And the work that we've been doing all along in high quality primary care has not been recognized by the payers. Like, I think that's the part where we want to really push the payers to support this kind of work. I recognize that it's probably a tough sell for them, but it's an opportunity to stabilize. It's an opportunity to allow us in primary care to take full responsibility across all ages and stages in the way we've been doing. And it will really, I think the results will really show. So would love to hear more about this.
So just a few comments about the states exceeding their growth targets, the history of that, and just plant a few ideas maybe we can come back to. First of all, to say that it's unlikely that here in California, the first time out, that very many of our hospitals or medical groups are going to be able to meet the target. Some may. Many probably will not, and so there'll be a lot of activity around the penalties and performance improvement plans and so forth. And one idea, or maybe others can expand on it, is that spending growth targets, the experience in other states and so forth, really are not going to change how our healthcare organizations earn their revenue, are not likely to change their underlying business models or behavior. And therefore, when one considers options to move that along, to do something like, for example, in the penalty phase, either reduce penalties, maybe waive them, if the organization, for example, to Sumana's point and others that we've raised over time, earn more of their revenue under risk-adjusted prospective payments. You can think global budgets in Maryland. There's other things that one can do as well. And you can use the HCI data to know where that cut point might be. It might be 40%, 50%, or whatever. So you're really using the penalty and the spending target as kind of a forcing function to nudge the organization into desired behaviors where the literature and evidence suggests that it does control the rate of growth and cost for the most part, and it does maintain or improve quality. ACO participation. You get a reduced penalty, a waiver, or what have you, if you have so much % of your revenue or your utilization under an accountable care organization. Again, where the evidence suggests that also results in a lower rate of growth in costs. Or in primary care. I know we have separate primary care targets and dashboards and so forth, but also they might get, some kind of reduction, if you will, if there are these greater documented investments in primary care, and we can think of other things, you've got to fundamentally change how our healthcare organizations earn revenue if you want to move the business models in a different direction than the fee-for-service and DRG-based, although there are penalties for readmit, et cetera, et cetera. So we can come back to that later on, but I just wanted to make that observation.
Thank you. Next, David, then Andrew and Hector.
First of all, Michelle, thank you. Very interesting things you pulled out there, articles and observations. I wanted to make three observations. One is related to private equity. I just wanted to share from Hill Physicians' perspective, many of the factors you pointed to as they relate to primary care, we also see in specialty care. So the same notion of private equity acquired specialists increasing the number of procedures, number of visits, and in particular, increasing the number of APPs much faster than the number of specialists. Sorry, Vishal, I feel like I'm talking to somebody who's not listening to me. Do you hear what I said? Are you having other conversations while I was speaking?
We had a little distraction because the next presenter has a time constraint. Apologies, David.
Okay. Should I wait, make it another time, my comments another time?
Yeah, David, if you want to go ahead and finish, then we'll let the presenter present and come back to these topics if we may.
All right.
Carry on. Thank you.
So exactly the issues you pointed to in primary care, I just want to make it clear, we see in some specialties which have been rolled up through private equity. So higher number of visits, higher billings. In particular, one issue we're concerned about is we've seen a dramatic increase in the number of APPs in these practices, and many of them are not being supervised in person anymore. They're being supervised by a physician who's available electronically, but not in person. And so that's a concern we have around, quality of care. So I just want to point that out. Secondly, I'm always curious that when I see discussions about the drivers of cost of healthcare, prescription drugs gets named specifically, but injectable drugs on the medical benefit often are not mentioned. So one of your points there about missing targets in other states, it wasn't mentioned. So from our point of view, because prescription drugs, while they're a concern, in terms of the trend, the biggest concern is injectable drugs, many of them oncology drugs that are increasing very rapidly. And I think it's just, for me, I wonder if maybe it gets a bit hidden because sometimes it's bundled with other payments where the treatment is happening at a physician office or a hospital outpatient center, et cetera. So just a heads up to make sure we're capturing that, because at least from Hill's point of view, the biggest single cost concern we have is the rapidly increasing cost of injectable drugs. You don't see them on the prescription list. They're not delivered in that manner. They're delivered through the physician office. But that's a dramatic increase in cost and often wonderful treatments with great outcomes, but very expensive. Third thing I wanted to say is I'm intrigued by the primary care idea, but I want to share two things. One is I worry sometimes we miss the forest for the trees. So the issue in primary care is very simple. It's not enough money going to primary care. We can have all these complicated conversations about it, but if no one's willing to step up and say, we need to spend more money in primary care, then to my mind, we're not going to solve it. And then the other thing I wanted to say is that we lump all primary care together, and independent primary care is in a totally different situation from hospital-employed primary care. So for PPO reimbursements, for example, the average reimbursement for an independent primary care physician from a PPO plan is going to be less than 100% of Medicare. The average reimbursement for a physician who is employed by a large hospital system that negotiates their rates is going to be north of 200% of Medicare. So more than double the payment rate. And so I worry that when we talk about primary care, we've got to understand that there's two very different kinds of primary care being delivered in California today. at least in the non-Kaiser system, you've got the independents who aren't able to negotiate their rates and get paid very, very low rates by health plans versus hospital employed primary care, which have a far better position in terms of their reimbursements and their economics. So I'll get off my soapbox.
All right. Thank you to the committee members for the comments and discussion on that. We're going to pause the comments here. I understand that one of our presenters has a time constraint, and so we will go to them and then come back to this discussion. Margareta?
Thank you all. Yes, thank you for your flexibility. If we could jump to the cost reducing strategy presentation. Thank you. So good morning, everyone. I'm Margareta Brandt, Assistant Deputy Director for Health System Performance here at OCA. And today we're joined virtually by leadership from the LA General Medical Center to present the Safer at Home program as an example of a cost reducing strategy. The LA General Medical Center team presented this program to the Healthcare Affordability Board in January, and we're excited to have them back to present to the advisory committee. As a reminder, the goal of OCA's Cost Reducing Strategies program is to highlight examples of successful cost reducing strategies that maintain or improve quality of care. And OCA is working with health plans, hospitals, and physician organizations to highlight examples of cost reducing strategies that have demonstrated results in their organizations. Another important note is that OCA did not independently verify the information about the strategies or the results provided by healthcare entities, and we are not endorsing any specific healthcare entity or strategy. We have identified these examples of strategies that can be a resource to others. And another note is that we are always seeking additional examples of cost reducing strategies. So if your organization has a strategy that you would like to share with OCA, we have a submission form on our cost reducing strategies webpage of the OCA website, and we will review your submission and follow up with you to learn more. So now I'd like to introduce our presenters from the LA General Medical Center who are joining us again virtually today. Dr. Brad Spellberg is the Chief Medical Officer at LA General Medical Center and developed the concept of the Safer at Home program with Dr. Banerjee. Dr. Josh Banerjee is the Associate Chief Medical Officer of Transitions of Care at LA General and built the first iteration of the Safer at Home program during COVID and hired Dr. Chris Lynch to run the program. And Dr. Chris Lynch is the medical director of the Safer at Home program and oversees its day-to-day operations, including implementing continual modifications and updates. Thank you all for being here. And again, thank you all, both advisory committee and presenters, for your flexibility. And I'll now turn it over to Dr. Spellberg.
Thanks, Margaret. We have very little time, actually. And so I don't know if it's desirable for us to come back. We'll try to go through this very quickly and just get to the discussion, but we're all going to have to drop off in about 20 minutes. Josh, do you want to go ahead and share slides?
Sure, you got it.
Okay. And then put it in presentation mode. There we go. And that's the end.
We can also keep the slides displayed on our end.
Okay, well, that's fine. Whatever's,
okay.
I mean, I can put them up, but I'm going to have to leave pretty soon, so I may not be able to finish.
Yeah,
okay.
I'm sorry, for some reason when I was sharing, it was only showing that view, like the other one popped up in my.
All right, look,
we can display the slides on our end.
I'm going to share them. We'll go quickly, okay? So this program is not hospital at home. We do not send staff to people's houses. The Medicare billing rules require in-person vital signs 3 times per day for hospital at home. We don't have enough staff to send all over LA County. So what this is it's hospital at home, but it's done virtually with remote monitoring, remote DME, and video visits. No IV medications are used in this program. Everything is done orally or inhaled. It was developed for COVID. We realized that COVID was going to put us under. We knew all the COVID. We were going to be the safety net for COVID, like we're the safety net in general for the county. And so we developed a program where we could send patients with COVID pneumonia requiring oxygen home from the ED. The program really did save us from going on triage during the COVID, that first winter in particular. We ended up caring for more than 4,000 patients. These are people who came in requiring oxygen from pneumonia that we sent home. If we didn't have this program, we absolutely would have reached the triage to life or death stage in that first winter. It worked so well to send people acutely hypoxic from pneumonia home that we decided, hey, how come we can't do this for other diseases? And so started expanding the program around 2022 to 2023 to a variety of other acute common illnesses. As Dr. Banerjee always points out, that the real breakthrough innovation here is the realization that the way we change practice, the way we practice medicine is changing based on clinical trials. We have this long-standing belief in medicine. If you give the antibiotics IV, it's more powerful, it's more effective. But we now know that's not true. And we can treat endocarditis with oral medications. So why are we admitting people to the hospital for IV antibiotics? These are 100% patients that would be admitted to the hospital with significant infections for IV antibiotics that are instead being discharged on oral antibiotics with close remote monitoring. Similarly, we used to admit people to the hospital with pneumonia if they required oxygen, but we now know we don't necessarily need to do that. So it is an evolution of practice based on recent clinical trials and clinical experience. We know that it's better to keep people out of the hospital. Hospitalizations cause harm events. It's also expensive, and it uses capacity for patients that really can't be taken care of out of the hospital. So the criteria essentially boil down to this. The patient would have been in the hospital. This is not enhanced outpatient follow-up for people that were going to go home anyway. This is for patients that otherwise would be in the hospital, but have a good chance of responding to the treatment. They have a predictable response to the treatment. And because we have enough monitoring, maybe they're in the ER for 3 hours and we see their vital signs are improving. Things are improving. So there's a low probability of very rapid decompensation. If they get worse at home, we have time to bring them back to the hospital. We've expanded to these diagnoses. So there's a whole bunch of patients who used to be admitted, things like heart failure, exacerbations, gallstones, alcohol withdrawal, a bunch of things, very common infections of a variety of types. And we have an ad hoc, so it's, if you have somebody who's not on this list, but if they can get virtual visits daily and we can monitor X, Y, or Z, we can keep them out of the hospital. You can call the on-call attending, discuss the case, and they can be enrolled as an other diagnostic category. Okay, so the process is very simple. The inpatient team or the ED has a patient they think might be eligible for safer at home. They call the on-call safer at home attending. They review the criteria. And if the receiving attending, the safer home attending agrees, then the patient is enrolled in the program. The enrollment is involved. Nurses teach the patient how the program works, provides DME that we stock in the ED and upstairs. DME is specific to each disease indication, but everybody gets a pulse ox pretty much and a thermometer. And then there are other things. If you have heart failure, we give you a scale, for example. And then within 12 hours of being discharged home, you will have your first visit with a nurse who uses a disease-specific script to go through specific questions and elements that are reviewed, and then rounds with an attending. There was a lot of work done to get adoption. You can imagine initially our physicians were very sort of reluctant because these people should be in the hospital, but over time, momentum built. They saw this could be safely done. And there were feedback that was given that they wanted a 24/7 process for the ED. And so that was built out, that we're able to enroll 24/7 from the ED, 12 hours per day inpatient, 24/7 from the ED. We have order sets that have been built out that have decision support for specific antibiotics, for example, that are prescribed. We have a staff-facing website that lists the criteria by disease indication and the monitoring that is done in the DME that patients will go home with. About halfway through the first year, due to having a bunch of patients who may not have ready phone internet access, is that we started dispensing a pre-programmed cell phone, a smartphone, with a simple, you press this button, you text the nurse, you press this button, you call the nurse, you press this button, you video chat with the nurse, and pre-printed FedEx labels so that the phones could be FedEx back to the hospital when the patient was discharged from the program. We do get 80 to 85% of these phones returned to us. The phones are not expensive. We have found this is an extremely cost-effective way to ensure access to patients virtually remotely. The results of the program are published in JAMA Network Open. In the first year, we enrolled 876 patients. We then used a complex matching scheme across DRGs, diagnoses, and vital signs, and matched those 876 to 1,590 control patients. They were very closely matched across virtually all domains, including case mix index and expected mortality. And the safer at home patients had an average of 4 days shorter in the hospital than the controls. Now, the cost of that 4-day reduction in length of stay is that we intentionally use the urgent care to check in if somebody needs to be seen. If the nurse does their daily virtual check-in and criteria are met, we will med Uber the patient back to the hospital to urgent care for a in-person visit. The cost of those 4 days of inpatient reduction is a 0.5 urgent care visit per patient on average. So we essentially traded 4 inpatient days for a 50% chance that the patient may have an urgent care visit. That is a trade we will make 7 days a week and twice on Sunday. We actually had a significant reduction in 30-day emergency department revisits and no significant change in 30-day rehospitalization and no significant difference in mortality. Second year, the program grew. Third year, the program grew. We're now somewhere between 3.5 and 4 patients per day enrolling. So I'm going to show you the financial analysis of the first year. You have to multiply that by 1.5. It's going to be 50% higher now because we're enrolling more patients than we did the first year. The financial analysis is complicated. How much time do I have? I've got just a couple minutes, so I'm going to try to walk you through this piece by piece. This again is also published in a separate JAMA Network Open manuscript. The first thing to note is that we have a very unusual payer mix. Even amongst public hospitals, we have a very unusual payer mix. 77% of our patients were Medicaid, 7% were uninsured, almost 85% a combination of Medicaid and uninsured. Tiny amount of commercial, and frankly, not that much Medicare either. That's why this program worked for us, because we don't get paid for this program because we don't meet Medicare criteria for a hospital at home program. This program saves us money by avoiding inpatient costs, but because we don't get paid, you are giving up inpatient revenue. So you actually do lose some revenue. We lost $4 million of inpatient revenue. You can see the breakdown across the payer category here by having these patients enrolled. But we avoided $10 million of inpatient cost. We lose money when we admit people to the hospital. We're a very unusual hospital. We run a 25% net negative margin because we have Medicaid, and uninsured patients predominantly. So it was the cost avoidance that made this program cost effective to us. There is $700,000 in fixed costs, that is salary support for 2 FTEs of nursing and a half FTE of hospitalist coverage, plus the cost of the DME. So net, $5.6 million of savings that first year. We net saved, obviously, on Medicaid and uninsured patients, and net lost on Medicare and commercial patients, which is why we're arguing and hope in the future we can get payment structure for delivering this care so that other hospitals will want to deliver this care as well, people that don't have as unusual a payer mix as we have. We've published a modeling analysis. If this program was reimbursed at about half a normal DRG payment, it would be cost neutral to society and payers and cost savings to hospitals. So you can save money and provide better care is the point here. I think that's it. I'll stop. I just have a couple minutes, but Dr. Banerjee might be able, and Lynch might be able to stay on a few minutes longer. Okay.
Or, yes, was there any more comments from the presenters? I couldn't tell.
No, yeah, well, I
Thank
think we
you.
can take Q&A. Yep.
All right, we'll go ahead and go to questions. David? Then Sarah?
Mrs. David Joyner, thank you so much. This is a fascinating program, very impressive. A quick question for you. When you determine a patient is eligible, is that presented as a choice to the patient or a requirement? I'm curious how that message is delivered.
Yeah, it's not a requirement. It is certainly encouraged because it's safer for the patient. Our experience, and Josh and Chris can add to this, is patients are thrilled generally that they get to leave the hospital. But no, they have to have a place to go. They have to have a home to go to. They have to have a stable environment at home. They have to say, yes, I will take these calls. If they do not want to go, they're not eligible to be enrolled in the program.
One moment, Sarah and then Stephen.
Oh, I'm sorry.
I had a question about the patients that are entered into this program and if they have caregivers, family members at home, typically more often than those that stay in the hospital. And I'm just curious because of my own personal experience with an elderly parent and that having care at home is really great, but it does require, like time off work and other supportive things that a parent or someone who's ill has trouble doing on their own. So I just wanted to mention that or ask about that because, there may be a cost to society, to families who have to accommodate taking care, helping with the supportive care of a very ill loved one at home.
So generally speaking, these are questions we get all the time, as you can imagine. Generally speaking, if someone needs intensive nursing care, they're not eligible to go home. They're not eligible to be enrolled in the program. These patients generally are patients that would be eating 3 times per day in the hospital, getting up and going to the bathroom. But they would be admitted to the hospital because they, quote, need IV antibiotics or they, quote, need oxygen. And so the answer is, if they really require that level of intensive support care, they're really not eligible to be enrolled in the program.
Thank you. Stephen?
2 quick questions, cognizant of your time. What percentage of patients do say refuse or you determine that the home supportive environment isn't adequate, roughly? Do you have numbers on that? Second question, very quickly, is you are a part of a health system, the USC health system. To what extent? You are not?
We are counted. We are affiliated with USC, but we are not part of the CAC health system.
Okay, unfortunate. I was going to ask about the spread to others that could adopt this program. What about the first question?
So I'll add to the second question quickly. The vice president provost at USC is very interested in virtual care models. And so we're starting to talk to them. We'd love to partner with USC more on this. It's been hard to spread even within the county system, interestingly. People have very fixed ideas about, well, no, they need IV antibiotics. This is hard. This is a new clinical thing. It's a way of thinking. Josh and Chris, maybe you could answer the percentage of people that are eligible that you get called about.
Yes, I can weigh in. During the early days of the program, we were recording every call. And it was about, we rejected 1 out of every 5 calls. I'm on Safer at Home call quite often, and it's roughly about the same.
Thank you. To one of our members attending virtually, Katina, go ahead, and then I've got Michael.
Hi, thank you so much for the presentation, Katina Murray, USC, and very interested in your program. I just had a question. I'm a family medicine physician. I just had a question about sort of the back end of things once the patient is sort of discharged from the Safer at Home program. Are there ties back to the primary care clinician, and sort of does that help in any way drive down readmissions. I saw your readmission rates are similar for those who are hospitalized, but any ties back to primary care after they've been discharged from safer at home?
That's a good question. We certainly do repatriate back into their network if they are out of network for us. But Josh and Chris, do you want to comment on that?
Yes, actually, before we discharge the patient from the program, we ensure that they have appropriate primary care and specialty care follow-up. And then for the non-GHS or out-of-network patients, we have support from our patient access center to coordinate follow-up within network.
Wow, that's amazing. I'll just say this is a true example of how innovation comes from crisis. So thank you for sharing your program.
Right. Yeah. Exactly right. And hope that we are able to build those bridges with USC, because I think there's a great potential collaboration.
Agree.
Thank you. Michael?
Hi, good morning. Based on the model that you've described, it sounds like the sustainability of the model is based on cost aversion in a managed care environment. Have you tested this at all with commercial payers outside of the capitated or managed care environment to see if they would cover the services?
We in county are not good at that kind of thing. And you know who is good at that kind of thing? USC. And so this is one of the things that we've been talking to Steve Shapiro about. And I think that there is the possibility to do that. We certainly in the future, when we renegotiate contracts, we'll be raising this. But right now, to your exact point, it is based on cost avoidance. We have not yet been able to get payment, and hope that we're able to figure out how to do that in the future. I'm going to have to drop, unfortunately, but Dr. Banerjee and Lynch can stay on for a few more minutes. I want to thank you for your time. We're happy to come back later and talk more if that's desired.
Thank you so much. Looking for additional comments or questions from the, yes, Sean, go ahead.
Hi, thank you so much for the presentation. Sean Kemp from Pharmacists Association. I was wondering about two things. Looking at the data, the population is focused on the Hispanic side. So do you see some language barrier? And if you do the virtual settings, like how do you overcome? That's the first question. And number two question is, especially about the med safety and med regs and adherence side, like when you're educating the inhaler uses, for instance, like how do you utilize, what's the best way to educate them other than doing it in person, or do you also coordinate that with community pharmacies around the area for the full care coordination? Thank you.
So that's a great question, Chris. Maybe I can take this one. So the two questions, if I recall correctly, one is on language, and the second is on pharmacy med education reconciliation. So the first question about language, actually making sure that we're communicating with patients in the language they're comfortable communicating in is foundation of our care here at LA General. We're really lucky to have really robust interpretive services, both on staff and then through contracted interpretive interpreters. And so that's just part of our practice here in general, both on site when we do the discharge education. So all the patients enrolled in the program get really intensive, careful, education and teach back before they leave the program. So that's done in whatever language they endorse as their most comfortable language. And actually, same thing when we do the virtual calls. Actually, even our phones are able to link us to interpreters to make it very easy for the patient and the staff. But we also have a lot of fluent Spanish speakers, which is like the majority language on our campus. So it's documented in all our notes. It's just ingrained as part of our practice, not just in Safer Home, but at LA General. And then in terms of the medications, you're absolutely right. I mean, when you leave the hospital, medications are always a safety concern, and really important that care team and patient are on the same page about what they're taking, why, and how. Our patients, when they leave the hospital, they're actually the part of that education is not just sort of the review of self-monitoring and understanding of their clinical illness, but it's teaching and demonstration back of how to use the self-monitoring equipment and the medications. The patients leave with the med in hand, so the nurses discharging the patients are actually reviewing the medications in hand with them. And so we try, especially for that piece, we actually make sure that we fill all the medications at our pharmacy, because our pharmacy team are really integrated with. We're all one integrated team. But at times, when the patient's discharged and we make adjustments to medications, we do need to coordinate with outside pharmacies, really the pharmacy of the patient's preference, and so we will review things. Either the nurses or the providers will speak with the pharmacy about if it's a dosing that we think the pharmacy might have questions about, or if there are potential interactions that we've considered, or if it's a medicine that we know we generally have here, but we're not sure if it's stocked in another medication at a pharmacy, we do have those conversations with them too. So we're pretty careful about it.
Great, thank you. Seeing no, yes, Janice, go ahead.
Sorry, just a question. What are the professional qualifications of the care team? And for the nurses doing the daily visits, about what does their workload look like?
So I'll take
per day.
Yeah, let me take the first question about the qualifications, and then I'll let Chris answer the questions about the volume that they take. So the Safer at Home team, this is a program that was started de novo here, right? So it wasn't, so it's not like there's like a pre-existing privilege or set of qualifications that were sort of identified, but it was co-developed by on the physician side, hospitalists, urgent care and primary care physicians, trained in internal medicine, medicine, pediatrics, and family medicine. And then a number of specialists, according to the different protocols. So infectious disease is very heavily involved with our team, cardiology, pulmonology. Some of our protocols, we have a MS exacerbation protocol developed with neurology. So that's that's sort of the clinical background of the physicians. We also have APPs now who are in the rotation of fielding some of the calls, also who have had experience in emergency medicine and urgent care. The nurses have been pulled from a pool of hospital and emergency and urgent care nursing clinical experience. So that's their clinical background, and they're the ones who are doing the discharging and then the daily calls. And then Chris, maybe you can speak about the volume a bit.
Yeah, of course, our volume varies based on, honestly, the diagnosis and kind of like our average length of stay within the program. So, for example, for heart failure exacerbation patients, they tend to stay in the program longer, about a week, compared to pyelonephritis, which is about 3 days. But I'd say the range actually is between 20, as low as 20 and as high as 40 patients a day. And so every day we have one APP, as well as a physician, as well as 2 nurses. But we have a pool of nurses that we can pull from urgent care on kind of busier days as well. And just in terms of like workload per patient, because we've protocoled these scripts and there's very standardized triage and escalation protocols, and also the call scripts are embedded into the EMR. The documentation actually isn't very time consuming. And so really it's mainly the calls with the patients themselves. And so if the patient is improving as expected, the call goes by pretty quickly, 5 to 10 minutes. However, if there is a concern on the call, such as patient is saying they have worsening pain or they have a fever, and then we're triaging, then we that may take some additional time to coordinate the transportation, but we also have clerk support as well. So I would say, it's not very time intensive for the patients that are just kind of going through the standard pathway. And typically our day finishes honestly like around 5 p.m. Sometimes even earlier at 3 o'clock when the calls are finished and everyone's been staffed. But we have the option of pulling in more nursing resources needed.
Great, thank you. Looking for additional comments or questions from committee members? All right, seeing none, I think that concludes discussion on this item. I'll turn it back over to Margareta to wrap us up.
Thank you so much, Dr. Banerjee and Dr. Lynch. Appreciate you joining, and thank you all for your flexibility. So if folks are interested, we are happy to, both the presentation is in your notes, and we're also happy to share the articles that the LA General Medical Center team mentioned with you all. And very much appreciate your time, and thank you so much. And yeah, we can turn it back to additional questions about any of the executive updates.
All right, thank you. I'm going to continue to pause the executive update discussion and make sure we do public comment on this agenda item that we just did. So we'll now recognize members of the public for a comment on the presentation we just saw. Please reserve comments on other items for the general public comment period. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually. Those in the room can line up at the podium. Those attending virtually can raise their hand. Those dialing in can press *5 to raise your hand, and it will track the order in which your hands were raised. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. And note that while the committee is committed to communication and transparency, members and staff will not be responding to public comment. Additionally, the committee may not discuss or act on any matter raised during the comment period that's not included on today's meeting agenda, except to place that matter on a future meeting agenda. Looking to the podium, we'll go ahead and start there.
Beth Capel with Health Access California. This is the second time we've heard this presentation, and we very much appreciate hearing it. Nobody wants to be sick, and nobody wants to be in the hospital. And people getting home sooner is a good thing. But we had the same question that Ms. Sorokin had about caregivers and support at home, because part of what happens when people move out of the hospital prematurely is the burden is put on the family. And so the careful attention that this program has built in is something, and the multiple daily check-ins, the looking for exacerbations, and the need to triage is something that might not necessarily be replicated as a program spreads. There's a innovation effect for people who have invented a program and are trying to get it right. So we appreciate that, and we also appreciate Ms. O'Malley's question about the nurse workload and the implications for nurses, because hospital care is nursing care. So thank you again for hearing the presentation.
Thank you. Looking virtually, seeing no hands raised, inviting anyone in the room who wants to make a comment to step to the podium. Noting for the record, we have about 80 virtual attendees, it looks like. Seeing no one at the podium, that concludes public comment on this item and takes us back to the previous item of the executive updates. And we were still in discussion and questions with the committee on that before we actually go to comment on that one. So I believe I had Andrew and Hector. When we paused, I had hands raised. Go ahead.
Yeah, so I guess, Vishal, I just commend OCA for tackling the GLP-1 utilization. Of course, when you show something like that, it's like a teaser, right? We have to do more studies, and it would be great if OCA can actually lead studies around ROI on these drugs, specifically by cohort, and also you have to track it over time, because think your data is through 2023. I just recall a period where every day there's an article that says, this thing cures this now, this thing fixes apnea. And of course, there's, all sorts of coverage changes that are happening, and, what's happening on unit costs, the compounding that's happening outside, and even, this month, right, Medicare Bridge program went in. So I think this is a fascinating area. I just encouraged continued studies, and, OCA would be a nice impartial source, because a lot of the ROI studies I've seen are basically sponsored by pharma. So.
Thank you. I've got Hector, and then we'll come to Michael. Hector, I had your hand raised before, but I know.
Yes.
Yeah, go ahead. Thank you.
Yeah, I didn't want to confuse with the other presentation. So yeah, I just wanted to go back to the comments that were made earlier. One quick editorial comment is, we went away at White Memorial. We went away from using APP as an advanced practice provider, because we now have advanced practice pharmacists. So APPs for us is a advanced practice pharmacist, and we use advanced practice clinician, APCs, as the terminology. So Dr. Reddy and David Joyner made some really interesting points on the PE side of things. That trend, not only on primary care, but also on the specialty side. And I see it more on the specialty side, where networks of anesthesiologists, radiologists, orthopedists, ENTs are being acquired by private equity, and the prices go up for the consumers, and at the same time, the cost of care is accelerated. And it's created a lot of distrust. What I'm hearing, when the Cedars-Sinai Anesthesiology Group unionized, they joined the Union of American Physicians and Dentists, was specifically because they were concerned about the behavior, in this case, of their foundation, replacing, exiting, or retiring anesthesiologists with CRNAs and putting a bigger burden of supervision on the anesthesiologist. So definitely you got to track that issue. On the primary care side, I think it's important that we begin looking at what Dr. Reddy mentioned, is how we value and support primary care physicians, and really how to fulfill the promise of primary care and confirm for ourselves the data that we believe, which is that good access to good primary care really reduces costs downstream and improves quality and equity. And I think part of this should be that we have I would suggest we have a presentation at a future meeting on standardizing the language of primary care, because in the delegated model, we see a lot of different models, and sometimes it's just kind of gaming of the system, where IPAs will have specialists who also are /generalists, and it's really for the purpose of increasing their enrollment, not necessarily because that specialist is ready and willing to provide primary care, especially the continuum of care that primary care represents. The second thing is that the PE model is really for maximizing revenue and lowering costs by replacing them with those APCs. And there's plenty of whistleblower cases that we need to look at. And then we also got to recognize there's some really good general practice physicians. So including them in the conversation is important, because many of them are at the end of their career, but they did not get the board certification that we look for, and yet they're very competent physicians. And then really looking at other trends in that regard. The last thing I wanted to mention is that in looking at a presentation to our advisory committee, and maybe to the board or both, is recognizing that a lot of the early life experience for patients is in the outpatient setting with their primary care. A lot of studies have shown that 70 to 80% of children and young adult interactions with the healthcare system is with their primary care physician, and almost exclusively, in that outpatient experience. The well-trained primary care physician also addresses behavioral health issues that are really important to address as early as possible, because that's how we're taught to take the comprehensive history of patients and be able to start developing a game plan for lifelong wellness for that patient and their family. And also, as patients age and we begin to see the prevalence of chronic disease, we do need to see that role of the specialist integrated with the care of primary care. So that conversation needs to happen of how we integrate that, how we look at the life continuum of patient population, and also how we avoid putting primary care physicians at risk for something they cannot control. They need to have a line of sight to the health plan and what they're doing, and the health plans need to adopt a new accountability to support the primary care physicians with or without the participation of an IPA. Ideally, that should be the IPA's role. Health plans need to hold them accountable for that. So that new accountability is something we need to include in this discussion. And I think among the folks that are part of this advisory committee, including Dr. Murray, we could come up with a list of folks that could make that type of presentation. So thank you.
Thank you. We'll go to Michael, then Ken, then Kieran.
Just a couple of comments on the health affairs hospitals exceeding their cost targets. First of all, thank you for distilling down a very complicated article into semi-bullet points, which is not easy. So that was very helpful. On slide 9, one of the sub-bullets, which says that market consolidation and weakening insurer bargaining leverage is studies point to that. It'd be great if we could maybe get that reference. If it's embedded in the article, that's fine, but I'd love to know that reference. And secondly, it would be great to also know if any of those states that are mentioned, if their cost targets were adjusted, or what did they do in response to this? Because I think there's a subsequent health affairs article that showed in Rhode Island that they actually had workforce reductions as a result of this. So it'd be great to see what kind of reaction occurred as a result to this too, if possible. Thanks.
Thank you. Ken and Kieran.
Yeah, thank you. I'm wondering if there's any plan to monitor the long-term use of the GLP-1s, with the ease by which people can get it now through advertising. And my concern is that we're going to find that there will be long-term after effects or increased costs due to the ease of access by people that maybe don't really need it.
Thank you. We'll go to Kieran and then Stephen.
Yeah, thank you for this. It's always really helpful. You get a number of the items on my reading list and summarize them for me. So it's really great. I want to second Sumana's suggestion about coming back to this idea of different financing models for primary care and what that might do also to overall affordability, because I do think there's something really probably interesting to look at there. And the article is a great start. And then I just want to add to the sort of articles you cited. There was a recent Gallup poll that showed for the first time a majority of Americans are unable to afford their health care. So we have gotten to that point. And I think it's important to sort of have that as part of the context, because that is really what we're trying to do here. And if we're at a point where majority of Americans cannot afford their health care, we're really getting to sort of the broken beyond repair place, in my opinion. And it makes the need for the complementary strategies that are called out in the article about the cost growth targets just all the more urgent, and the understanding that what we do here is essential but not sufficient. And so just continuing to, I think, keep that in mind is helpful. Thank you.
Thank you, Stephen.
Yes, to answer your question, Michael, it's my understanding in Rhode Island that for a couple of years, what they did is they did implement price caps along with spending growth targets, right? In the following year, they did get the reduction. Not subsequently, though. Now, what I'm not a little less sure of whether they got the reduction through workforce shortages or not, but they did combine it with price caps, and they're the only one, correct me if I'm wrong, Vishal, that for a while did actually see and meet the targets, but they also use price caps.
Thank you, Katie.
Thank you for the presentation. I thought it was very interesting to see the PE related, the cost increase. I think it's the challenge of how the healthcare system was built on fee-for-services model. But it'll be also interesting to see the relationship between the payer as well as the provider. There must be some type of correlation as well. May lead us to some insights. The other part is the GLP I think there are different types of costs they were talking about, whether it is the manufacturer cost versus, why is if we're measuring the AWP versus WAC price, then if we do, then what's the rebate price and how is it different? Depends on which pharmacy or which health system they are contract to. Depends on the beneficiaries too. So there are different aspects that we need to distinguish when we're talking about the cost. And I highly encourage the OCA to think about how to distinguish different prices. Thank you.
Thank you. We'll go to Katie.
Thank you. 2 points. Regarding slide 9 and market consolidation, I just want to reference the report that the OCA staff completed on Monterey County, which was definitely part of what our problem is in Monterey County is market consolidation. And then the second is I just was made aware of the UCLA study and the webinar, and I'm wondering if that report was part of the unified pathways to unified healthcare financing with primary care.
Katie, what's the question? Sorry.
So there was a
Right.
report.
I know the report.
And I'm wondering how that is with the
Yeah, I would say it's a parallel effort.
it is okay.
Yeah, Cal HHS is leading that. So if folks know, I mean, it's a substantial report required by Senate Bill 770 to look at different unified financing options. And yeah, there is a 1 hour long webinar that folks can watch, and there'll be some upcoming panels and the like.
Okay, thank you.
All right. Yep, David.
One more comment on the whole GLP-1 debate. Obviously, there's evidence of benefits, but there was a JAMA article that showed that the net effect was a net increase in healthcare costs. In other words, the cost of the drugs were not offset by the savings in terms of improved health status, reductions in diabetes treatment, and so on. The analysis said that you'd have to get a 60 to 90% reduction in the healthcare costs of GLP-1s to see a net benefit. So I think GLP-1s are very interesting, but at the moment, the evidence says the cost is so high for the treatment that it's not offset by the healthcare benefits yet.
Thank you. Any additional comments or questions from the committee? All right, that'll take us to public comment on the executive updates. So if you'd like to make a comment on that agenda item, please step to the podium. If you're attending virtually, please raise your hand. Please limit your comments to 2 minutes if possible. Look into the podium. Go ahead.
Beth Capel with Health Access. Having read the report by Michael Bailett and others on cost targets in a variety of states, one of the things they point to is the enforcement mechanisms that OCA has that you're going to spend the rest, including at the end of a very lengthy enforcement process, the potential of penalties that you will spend the rest of the day mostly discussing. So this is part of the work of making the cost targets actually effective in California. Thank you.
Thank you. Looking virtually, seeing no hands raised and no one at the podium, that concludes public comment on this item and takes us to our next agenda item. We are right back on schedule. So non-supervisory organized labor adjustment data collection regulations. I'll turn it over to Assistant Deputy Director CJ Howard.
I do my best to get us back ahead of schedule. Good afternoon. It's not afternoon. Good morning. Almost afternoon. Potentially, I'll be the last voice you hear before we go to a lunch break. My name is CJ Howard. I'm the Assistant Deputy Director over the Healthcare Spending Targets branch. Just going to be providing a quick update on the non-supervisory organized labor adjustment data collection and the data collection regulations. I know that we discussed this at our last advisory committee meeting. So we can go to the next slide. So this slide was presented at the April Advisory Committee meeting, and it's presented here as a refresher. And so just to summarize, spending targets may be adjusted when non-supervisory employee organized labor costs are expected to exceed cost targets. Providers or fully integrated delivery systems must submit a formal request in an OCA prescribed format and other associated third parties. The request must include supporting documentation such as a final labor agreement. OCA may request additional information to validate the request and may audit submitted data and documentation as necessary. Requests must demonstrate labor cost growth exceeding applicable targets. They've already moved to the next slide for me. It's like they knew I was going to say next slide. So OCA posted draft non-supervisory organized labor adjustment data collection regulations for public comment on June 23rd. The regulations can be found on HCI's website. Regulations define who may request a spending target adjustment and the information to be included with the request. They also incorporate file specifications document by reference. The file specifications document details the format and contents of a data file to support the request for adjustment. Public comments are due to oca@hci.ca.gov by Monday, July 13th. Next slide. OCA proposes to collect data from requesters such as hospitals or physician organizations to facilitate labor cost analysis and calculation of a potential spending target adjustment. Data elements in the file specification document include both current and projected hourly wage information, current and projected personnel costs, and current and projected total operating expenses. With this information, OCA would be able to calculate the cost of each reported labor contract as a percentage of the entity's total operating expense and determine how much projected growth could be attributed to organized labor costs. This information can then be used to calculate a proposed adjustment to the entity's spending growth target. Next slide. This slide provides an example of, so we also discussed this at April, but this slide again provides an example of how OCA could use the current and projected cost information requesters submit to calculate an adjusted spending target, which would then be presented to the board for its consideration. In the stylized example on the slide, where a provider reports $100 million in expenses, one labor group's costs are projected to increase by 5%, another labor group's costs are projected to increase by 7%, and the remaining 68% of costs are projected to increase by 3.5%. Multiplying each projected growth rate by its share of total expenses creates a weighted growth rate, which are summed to produce a preliminary adjusted target value. Next slide. So this slide shows OCA's projected timeline for the non-supervisory organized labor adjustment regulations or data collection regulations. Today we're discussing the draft regulations with the advisory committee in anticipation of sharing your feedback with the board in August. OCA plans to submit the regulation package to the Office of Administrative Law in September, and if approved, entities will be able to submit their first requests this October, which would then be applied to the 2028 performance year. I will turn it over to the facilitator to facilitate discussion.
We'll now take discussion on this item. David, go ahead.
Thank you for the presentation. I wanted to ask, if I was the CEO of a hospital competing with another hospital that has a collective bargaining agreement, which results in increasing the hourly rate, and I have to raise my hourly rate to match my competitor, what process do I have as a hospital to submit that cost escalation into this process? I'm not unionized in this case, but I'm having to match the union rates.
Yeah, I hear you. So I think the statute explicitly calls for adjusting the targets on the front end for non-supervisory organized labor costs. We also know that there's through the enforcement process for an entity that does exceed the spending target, that the entities will be able to, through the 45-day process after exceeding the spending target, be able to submit information for the office's consideration when determining which entities may or may not proceed with further enforcement beyond technical assistance when the spending target is exceeded. So I think that one of the most clear and obvious cases would be during that process.
Thank you.
So there isn't a similar,
Otherwise,
there isn't a similar front-end adjustment process available
Okay. What
for non-organized labor.
and is it because you don't agree with that idea, or is it because you think the regulations don't allow it?
That's what the statute calls for. So that's how the bill was negotiated, and we have to comply with it.
Thank you. Sarah, then Andrew.
I understand this is the statute, so it's something that the board is tasked to do, but I'm wondering about if there's any clear data that shows increased organized labor costs go along with increased costs to these entities, meaning are there ways that it actually reduces costs, like in terms of reduced turnover or other benefits to having a workforce that's compensated fairly and has good or better working conditions? Yeah.
Yeah, thanks for the question. So I'm not aware of any data or information about the adjustment and other impacts that may be beneficial, but or spillover effects. But we do have the workforce stability standards that do touch on the importance of having a stable workforce and the turnover rates, recruitment and retention rates, like all of that is part of a different work stream that OCA has.
Thank you. I've got Andrew, Joan, then Barry.
Yeah, just wanted to confirm just a quick exchange you had with David Joyner. I mean, the enforcement process on the back end will allow for an adjustment for organized and non-organized labor costs. It was what I heard.
It wouldn't be an adjustment, but the 45-day period allows entities to give OCA additional data information. So if one of the causes was non-unionized organized labor costs exceeding, the entity does have an opportunity to bring that information forward to OCA, and then on a case-by-case basis, OCA could evaluate that information and decide whether, to proceed to the next step or just kind of, the entity's just going to get technical assistance and that's it.
Yeah, and I guess, Michelle, I just wanted to confirm that also applies to organized labor costs.
Yes. Yeah.
Right, because I'm just thinking timing.
Yeah.
Right, so we're trying to set a target for 2028, like, before the year, starts and, early next year. And it's one of those things where most entities probably won't have contracts locked in. So it's a situation where, what do you even submit at that point, right? It almost makes sense to do it after the fact when everything is actual.
And it may make sense for some entities to do it that way because the timing just doesn't work out with our board calendar for adjusting targets.
Thank you. I've got Andrew, Joan, Barry, and then Cassie, one of our new members attending virtually. I see your hand raised also. Joan, go ahead.
So I've got some general comments and then also some feedback on both the regulations and the specification document. We'll also be submitting written comments on this, but do just want to give a little bit of flavor on those. Starting with thank you for moving forward with this quickly. Really appreciate that we'll be moving forward quickly enough to be able to get these submissions in this year for the 2028 calendar year. That's fantastic. And appreciate the clarification on also then the considerations on the back end, since there isn't a way to do it for 2027. And we know that those costs are growing faster than targets. Understand that this is the first version of what will undoubtedly be iterative. There will be things that get substantially easier in year 2 of an entity's submission, and there will be things that we find where we don't have quite enough information. So we're thinking about this very much as let's get this built for this year and then iterate on it. So would encourage not locking in too much and assuming that we're coming back to this. in terms of the actual regs and the specifications document, I don't see a mechanism for the union to be the applying party. The specifications document is pretty clear that even so, field 1 is requesting organization, and it's very clear that that's meant to be the regulated entity, not a labor union. Am I mistaken in that, or how would that actually play?
No, our intent as we're building this, so we're trying to do two things in parallel here, and they're, as you've noted, somewhat complicated in terms of the data that we need to get to build this, and then also build the system, and then also describe said system in regs. So I can tell you that the intent is that the labor union would be able to at least initiate. To be really candid, I don't think that we're at a place, and as we're building it and open to have more discussions about this, before it being completed, we still need to have, like, so that there's going to be a process, right, where you come in, you start a request and you fill out information. The regulated entity would have to also sign off on what's being submitted on their behalf. So there is a step in there, but again, the organized labor union would be able to be involved from start to end. There is a midway step where there's sort of an attestation from the regulated entity that says, yes, I agree with what's being said about my facility or entity.
Got it. That could probably use a little bit more specificity in the document.
Happy to have that feedback. Yeah.
Yeah, that's not clear in this. And so what I'm hearing there is that if the union submits the initial application, there would be a second party notification to the employer, to the entity.
I don't want to speak out of turn, but I'm happy to have further discussion.
Well, no, but I'm just checking for understanding.
That's the intent.
Okay.
Yeah.
Would there then be the flip side of that? If the entity, let's call it a hospital, submits, would there be?
I don't think that it's currently drafted that way, but we're open to.
Would love to see that, because we could definitely see a hospital or an entity submitting with assumptions that are not consistent with the assumptions of the union. And it would be much easier to catch that on the front end than to catch that in public comment at the board. So that would be very helpful to make sure that there is that two-party notification, especially if the union is the one submitting, if there's automatically going to be a counterparty notification to the regulated entity, then we definitely want the same consideration going the other direction. And so that's one thing. I would encourage on the requester type to also allow for other. Right now it is specified only as hospital, physician organization, and FIDS. And we definitely represent entities that don't fall into any of those three categories that are regulated entities under OCA, for example, FQHCs. And then under sort of that number 11, which is the classification description, the occupation classifications are the HKI, HAFD, like financial classification descriptions. Those don't map perfectly onto the National Labor Relations Board's bargaining units. And so you're going to have a lot of unions. So like if occupation classification is number 1 is technical specialist, 2 is RN, 3 is LVN, et cetera. It would be very common for a bargaining unit to represent several of these. And so figuring out what it looks like to be able to actually just physically report that, whether it's giving each of those classification descriptions sort of a yes, no checkbox even. And so it would be possible to say like, yes, technical and specialist, yes, aides and orderlies, Yes, environmental and food service. Great. And then on one slide before this, where it goes into some of the description, if you can back up one slide if that's possible. The current costs versus projected costs, that feels like the right question to ask, and it doesn't quite map onto the specifications document. The current costs in particular, the specifications document is asking for average hourly rate and current productive hours, and that doesn't actually map onto current costs particularly well. It would if we had a perfectly normal distribution of hourly wages, but we don't. It's a very lumpy distribution. And then also average hourly productive hours does not map particularly well onto average hourly wage. You're going to have some classifications that are going to end up working a lot of overtime and some classifications that aren't. And those don't map well. What we do actually have is the data to do current costs. Either the union or the employer can get you a pretty accurate current costs. And so it might be worth asking for that instead of averages. Yeah, those are some of the things in terms of something that is, oh, and on that also, paid hours, not productive hours. I know productive hours is what the current reporting is, but that doesn't match particularly well. The other thing, it would be very helpful to have sort of a linkages specification. A lot of our contracts cover multiple regulated entities. For example, if you have a hospital that also has an affiliated medical foundation, it's very likely that those are going to be in the same contract. Or if you have a small system of 2 hospitals, those are very likely going to be in the same contract. It would probably be useful to be able to start building that linkages list through the submissions of, okay, what regulated entities are covered by this contract? Because we know we'll have to do each of these adjustments at the entity level. But if you've got 3 contracts or 3 entities, they're all under the same contract, it'd be helpful to know that at the start. So we'll have additional comments in written, but that just wanted to get some of those out there to start thinking about both how to simplify and how to refine.
Great, thank you. Got a couple folks ready to make a comment in order. We've got Barry, Cassie, Mike, Tam, and Sean. Barry, go ahead.
Thank you. And I appreciate Mr. Joyner pretending to be a hospital administrator in his question, a question that I've raised a number of times over the last couple of years. No, actually not. So my question actually pertains to this process, not the question I usually ask about non-organized entities. It's trying to do it in the future. And so you go through this analysis. I like that last slide you were just on a minute ago, CJ, which showed what was actually used in the calculations. And trying to project, because what OCA measures is net patient revenue changes by Medicare, Medi-Cal, and commercial year over year, in a future period. They're trying to take a current negotiated contract and say, here's how much we believe we're going to get more from the commercial health plans. Because again, that's what OCA is measuring in the cost cap. It's not operating expense. It's the net patient revenue as reported by the health plans. And in any given year, the number of health plan contracts that might come up for negotiation during that period that we're focused on might be 0. So there'll be no impact it wouldn't affect our cost cap. It might be 1 contract, 4 or 5 contracts. It may represent 10% of their business. It may represent 50% of their business. So it's an extraordinarily subjective exercise. It'd be very difficult to know how much it actually impacted what OCA is measuring, which is net patient revenue as reported by the hospitals or the health plans. I think the process that you're signaling might be possible during the enforcement period if a non-organized entity exceeds the cost cap and can come back and say, yes, we did have a negotiation with XYZ Health Plan. We achieved a 5.5% increase in our rates, which flows through and shows up on the net patient revenue numbers. And 20% of that was attributable to this union contract, which we signed 18 months earlier. Very clear, very objective. So I'm just curious how you're kind of apportioning their increase in operating expenses, therefore then to the change in what the cost cap is measuring, and they're not the same thing. Does that make sense?
Yeah, it is because we're relying on projections. It is an imperfect approach. So yeah, on the back end, and even if you do request an upfront adjustment, we would still, and you exceeded the target later, and you received an adjustment for that year, we'd still want to know kind of, did those higher than expected organized labor costs materialize, so that we could, validate that the target that was approved was appropriate. But for some entities that don't seek an upfront adjustment, whether it's just the timing doesn't work out or they don't have the data in front of them, it could be they could probably be more accurate on the back end because they'll have the actuals in front of them.
Thank you. Cassie, Mike, Tam, and then Sean. Cassie, go ahead.
Thank you. My question is similar in spirit to the last one. So from a health plan perspective, ultimately all these labor increases flow through to the health plan through our negotiated rates and flow into premium, which is measured. And so would there be consideration for the health plan targets for the labor cost increase when you're measuring how a health plan is performing?
Under the law, it's really focused on providers and fully integrated delivery systems. So there is an equal process for the same process for the plans. In terms of an upfront adjustment, but as I mentioned earlier, we have those enforcement considerations. So that's the entity's opportunity. So a plan could explain the causes of spending growth, and if it was, part of the spending is due to, impacts from other sectors, they could demonstrate that, then we could consider that.
Thank you. Mike, Tam, and then Sean.
Yeah, thank you. And I just wanted to echo Joan's concern about on the labor side being notified when an entity has submitted their, projections for organized labor cost adjustments. I think it's, it'll be really helpful, and ultimately you'll end up with a more accurate projection if all parties are looking at the numbers and collaborating to some degree. So I'd just like to second that. And yeah, just appreciating the work going into this and the timing. I think just to say a word about we really believe that organized workers add value to their organizations. There's some concern, a concern was voiced around unorganized worker cost adjustments, and I just think there's a lot of value added to having organized workers, especially organized nurses, organized healthcare workers in general, in terms of stemming the shortage of healthcare workers, reducing turnover costs, creating sort of occupational cultures that improve patient care, professional development. All of these things, don't exist to the same degree that they would, without unions. So I think this, it's very appropriate that we are, looking at these cost adjustments for organized labor. Yeah, there was one other point, but it's left.
That's all right. You can raise your hand again. I'll come back
Thank
around.
you.
Tam, Sean, and then David, please.
I want to thank the OCA team for the work on these organized, non-supervisory organized labor costs. They echo some of the comments that Joan Allen had raised about being flexible in this process as we learn about how this could work and also all the nuances involved. And as a university that has multiple labor contracts, we're thinking about how this could be operationalized, and how we could go about requesting the adjustments, providing the backup information, right, and data to support such adjustments. So we just request that OCA, work with us and other entities and with organized labor on, thinking about how we might be able to reduce the administrative burden all around, especially in a setting where there are multiple contracts that start and end at different times, and the challenges with projecting costs, into the future as well. So we'll be submitting some detailed comments about the regulations and the data specifications, but wanted to give a flavor of what we are thinking about as we work with you to operationalize this process.
Thank you. Sean, David, and then Mike.
I just wanted to echo to Joanne's comments about the regulator types of, there are some of like FQHCs and community-based organizations, so putting other will be appropriate. And also looking at the classification description, it's missing pharmacists and pharmacy technicians that were also labeled unions. So we'd love to encourage to include those. Thank you.
Thank you. David?
I hate to disagree with my new colleague here, Mike, but I totally disagree with the notion of applying a different standard to unionized versus non-unionized workers. To me, they offer the same value, and I'm very uncomfortable, as you can tell from my comments, with the notion of measuring them differently. I also think we should just take a step back here and say, if this is about affordability of healthcare, I think we've got a giant issue here in terms of unintended consequences. Because if I'm a unionized hospital, it's very logical for me to say, the best thing for me to do to get a higher trend target is to early negotiate a high increase with my unionized employees, get a higher trend target, which is easier to meet. And my competitor across the street who's non-unionized, they have to go and beg for forgiveness. They don't get the pre-loaded higher trend given to them. So I understand you're saying it's in statute, you have no flexibility, but I still believe it's worth expressing my concern about the process.
Thank you. Mike, I know you wanted to follow up with a previous comment.
Well, I only wish hospital CEOs were so willing to, agree to large wage increases. I don't think that's the danger that we face here. I mean, there is an affordability crisis, and sadly, it's going to, the costs, are going up based on this, entire fragmented system we have, and I don't think we can put that on the backs of organized labor. There's many other things driving those cost increases, and I think if you look at the profitability of many of the unionized hospitals, you'll see that that many of the cost increases aren't going into the pockets of workers, but hundreds of billions into the into the hospital systems themselves. And that's not to say there's I mean, obviously there's rich hospitals and poor hospitals, and many of them are unionized, and that's not the difference, right? So, but I think coming back to this issue, though, I think, which is somewhat related to your comments, but I just wanted to make sure to mention, these projections are challenging, and they're not actuals. And I mean, anybody who's looking at budgets or done budgeting, the projections are always wrong. So to some degree, the more effective way of dealing with this is not, I mean, you have a target, but everybody's going to have to go to justify why they're off target. I think, and looking at the actuals, and I think that's really the more, that's a very important piece of this whole process that I think, obviously we're talking about, adjusting targets, for the future, but we all need to be prepared for dealing with the fact that those targets are going to be incorrect, and we're going to have to look at the actual costs. And I think unionized, non-unionized hospitals will all be going through that process as well. So just wanted to make that point.
Thank you, Andrew.
So I think actually to agree with Mike on the best way to do this is on the actuals on the back end, right? Because the projections are just going to be tough and changing all the time. And if you're going to do a back end anyway, I know that it's in the statute, right? I'm going to ask a question of, why do we want to do all the front end iterations if it's going to just be in the back end? And that's the real measure at the end of the day.
Thank you. All right, seeing no members attending virtually, Joan, go ahead.
Yeah, just a quick piece on that for us as we were working toward the language on this in the statute. Part of the thinking really on this language broadly is to make sure that workers' ability to organize and to bargain fair contracts is held sacred. That's a value here in California. And so figuring out how to square that with OCA is hard, and it's going to take time to really get it right. But just wanting to go back and remember that is one of the values on which this was built, was the idea that an organized workforce is good, and both for the workers and for the community, and for patient care. And so thinking about how we can make it so that we are doing the least harm possible to that organizing and bargaining potential.
Thank you. Looks like that concludes discussion and comments and questions on this agenda item. Noting that our virtual attendees, we have no hands raised. So that takes us to public comment on this item. If you'd like to make public comment, please step to the podium. If you're attending virtually, please raise your hand. If you're dialing in, please press *5. I'll go to the podium.
Hi, Ben Johnson with the California Hospital Association. Slipping up here, have not changed sides. We're talking about labor. So just want to remind, labor costs are 60% of everything that hospitals spend on providing care for patients. And do also want to remind that OCA does have authority to adjust the targets for various factors, including all labor costs, prices of health technology, inflation, other factors, but it is electing to only do the mandatory adjustment that is in state law. But we encourage OCA to take into account the variety of factors, the variety of drivers, and adjust targets for those things that are appropriate and predictable, include and do so in a way that is equitable to all workers. Thank you.
Thank you. Looking virtually, seeing no hands raised, back to the podium. Can you confirm the mic?
Off. Okay.
There you go.
All right. Good afternoon, everyone. Beth Malinowski with SEIU California. Just want to really appreciate the conversation happening today. As was noted by Joan Allen, just really appreciate the pacing of work by the staff team and the work that's getting done to make sure we hold to the timelines that we have before us right now to make this actionable in the fall. Really just want to second and highlight a couple of the things that were said by Joan, which are really important to the broader SEIU family. In particular, as we think about the activities of this fall and who's submitting the information, just just really want to second underscore the importance that labor has the opportunity to initiate those submissions, but appreciate the points made by staff in terms of how do we make sure we're engaging with employers in that process. And we'll speak to that a bit more in the comments we submit. On that same vein, want to also speak to the importance, as was again noted by Joan, that labor can also see what employers or our entities here are submitting along the way as well. So we can make sure that we are attesting to its accuracy as well, recognizing how important this information will be for final actions taken by the staff. Additionally, just want to appreciate some of the back and forth that happened here regarding accountability and Vishal, in particular, the comments that you made in terms of making sure that even after adjustments are made, that we are guaranteeing that there are eyes on making sure dollars are moving where they should move to our workforce, and that role of additional accountability that will be happening by the team here, OCA, both staff and board. Just appreciate that work in advance and look forward to ongoing conversations. Thank you.
Thank you. Looking back virtually, no hands raised. Go back to the podium. I'll give it just a moment, seeing no one at the podium, and go ahead and, okay. That will take us to our next agenda item.
Well, we're going out of order.
Okay.
We're going to go out of order and take the CMIR updates next. Right?
Yeah.
Great.
So we'll do the CMIR updates, give you lunch, and then we'll come back and talk about the spending target enforcement.
Right, good afternoon. My name is Heather Klein-Hogenson. I am one of 2 assistant chief counsels in OCA's compliance unit. I use she, her pronouns. Bring that a little closer to me. There we go. We're talking about some CMIR updates and regulations. We last talked about the transactions that OCA was reviewing back in January. So since that last report in January, OCA's Transaction Review Program, our CMIR program, has had its 2nd anniversary. Yay. In 2 years, we reviewed over 45 transactions and concluded 1 CMIR, a cost and market impact review. Our average time for those transactions that were waived was about 26 work days between being deemed complete and the issuance of a waiver. Since January, we've gotten 9 transactions submitted with 15 different submitters because a transaction could have multiple parties. Sometimes it's only 1 party filing, and sometimes we have 2, 3, or 4. We've also had 8 pre-filing meetings, generally with law firms, as a transaction is being reviewed by various law firms involved in the transaction. A lot of times they will call and say, do we need to file, or how could we best file? Could we submit some things together jointly? Things like that. So we engage in those conversations regularly. Next slide. From January to June, we've had less skilled nursing facility transactions than we've had over the past 2 years. That's gone down a little bit, but laboratories have gone up. And we're also now starting to see more transactions with MSOs. Next slide. So since January, we've completed 11 transactions and waived them. We also completed 1 CMIR. I'll talk about that in a second. We have 4 open transactions. Next slide. Okay. So ResCare was our first completed CMIR this spring. A full discussion of that transaction was presented at our May board meeting. So if you're interested in that, the economic expert discussed some of those issues. Next slide. We are still working on a CMIR for Covenant Care, and that is regarding the acquisition of 3 skilled nursing facilities by the Ensign Group. And that's still under review. Next slide. So as to ones completed since January, Care Meridian was waived in January. That's Sierra Summit Head Injury, an adult residential rehabilitation service provider in Placer County. The Sierra Summit was not a healthcare entity under OCA's rules, but it was being acquired by Care Meridian, who is a healthcare entity. Next, we had Physician Health Network Medical Corporation. That was a transaction referred to us by the Department of Managed Healthcare. On the retirement of some physicians in that corporation, ownership was being transferred to David Olek, MD, and Eva Vargas, RN. That IPA is comprised of approximately 40 primary care physicians with an extended network of over 500 specialists and serves Medi-Cal patients in San Bernardino and Riverside counties, contracting with the Inland Empire Health Plan. And that was waived January 16th. Euclid Endoscopy Center. They own and operate 2 endoscopy ambulatory surgery centers in San Diego, ASCs. Both ASCs specialized in outpatient gastrointestinal services. AmSurg operates 250 ASCs across 34 states with 25 ASCs in California. So for this transaction, which was waived June 25th, AmSurg will increase its presence in San Diego from 2 to 4 ambulatory surgery centers. Next slide. Imperial Care and El Centro Regional Medical Center, that was waived in February. This transaction was a 123-bed skilled nursing facility transferring to El Centro Municipal Hospital and the Imperial Valley Healthcare District. Imperial Care is one of 3 SNFs in Imperial County. And then Abbott Labs and Exact Sciences, that was waived in April. Abbott is headquartered in Illinois and is a global leader in chronic disease management. Exact is headquartered in Wisconsin and focuses on oncology diagnostic products such as Cologuard. In this transaction, Abbott would acquire Exact via a merger, allowing Abbott to enter the oncology diagnostics market. Both companies have large research teams in Redwood City and in San Diego, California. A federal filing under the Hart-Scott-Rodino Act was required, but there was not action by either the FTC, Federal Trade Commission, nor the U.S. Department of Justice. And that was waived in March 19th, sorry. And then, thank you, Sharp Healthcare and Tri-City Healthcare. That was waived in April. Tri-City Healthcare District owns, operates, and does business as Tri-City Medical Center, a 36-bed acute care hospital serving North San Diego County, primarily the cities of Oceanside, Carlsbad, and Vista. Tri-City also operates primary care and specialty outpatient clinics in the area. Sharp is an integrated healthcare delivery system operating 4 acute care hospitals, clinics, SNFs, etc. As of September 2025, it operated 2,230 licensed beds. Sharp also provides healthcare services through Sharp, Reese, Steely, and Sharp Care, operating 17 multi-specialty clinics throughout San Diego County. Under the 30-year agreement, Sharp will operate Tri-City, investing in North San Diego County. Sharp has committed to reopening Tri-City's closed service lines. And Tri-City's Healthcare District's Board of Directors will transition to a community oversight function, remaining accountable to residents. The transaction was subject to voter approval in the June election, which I believe was approved. And that was just a couple weeks ago. So the next slide. Inform Diagnostics and Fulgent Therapeutics. That was waived in February. Inform Diagnostics is a national clinical laboratory headquarters in Texas, and they operate 3 locations in Southern California, Anaheim, Oceanside, and Palm Desert. They serve Los Angeles, Orange, Riverside, San Bernardino, San Diego, San Luis Obispo, Santa Barbara, and Ventura counties. Its parent company, Fulgent Genetics, provides clinical laboratory services nationwide, but is headquartered in Los Angeles and serves LA and Orange counties. Under this transaction, Informed will acquire equity and assets from Baco Pathology, LLP, also nationwide, They provide anatomic and clinical pathology services. The subsidiaries being acquired include a lab in Massachusetts and Georgia. While BACO does not have lab operations in California, it does accept specimens remotely, about 5% of its operations. Our next transaction, UC San Diego Health and Palomar Health, was waived in January. Palomar Health is a public health district operating Palomar Medical Center, Poway, which is 107 beds, and Palomar Medical Center Escondido, 318 beds in North San Diego County. Due to Palomar Health's worsening financial situation, parties agreed to form a 7-year joint powers agreement, which will include University San Diego and Palomar board seats. Each hospital was to have new individual licenses, and certain NICU beds will transition to Rady Children's Hospital in San Diego. Parties hope to expand the region's cancer center, women's health services, and cardiovascular services. OCA confirmed with the parties that the joint powers agreement does not intend to index pricing to academic levels, but would instead benchmark to community market rates. And then OCA published a supplement to our online notice with further details for that JPA. And that was waived March 24th. The next one is Vitalant and San Diego Blood Bank. Nonprofit Vitalant operates 32 facilities in California for blood-related services, all north of Ventura County. Nonprofit San Diego Blood Bank has 10 donation centers in Southern California. Vitalant already contracts with San Diego Blood Bank to provide Kaiser with blood-related services in San Diego County. So San Diego Blood Bank will operate as Vitalant's wholly owned subsidiary at the close of the transaction, and that was waived March 3rd. Next. So the Centene transaction was waived May 4th. Centene, a publicly traded managed care company, is divesting certain Magellan entities in this transaction, including employee assistant programs in California and an MSO for telehealth provider group, and also a life insurance company, which no longer has active business in California. DMHC had referred this transaction to OCA pursuant to the authority in the Health and Safety Code. And next. Vibra Hospital of San Diego and California Rehabilitation Institute. This was waived mid-June. This transaction involves the acquisition of a large and publicly traded company, Select Medical Holdings Corporation, that owns and operates rehabilitation hospitals and management service organizations in California. The Intermediate Corporation is a newly formed entity owned by the Stallion Group parent, which is indirectly owned by a hedge fund affiliated with Welsh, Carson, Anderson, and Stowe. They're described as a multi-time capital partner of the seller, Select Medical Holdings Corporation. The transaction is structured as a public to private leveraged buyout. And then the two MSOs involved, SMCS and Matrix Rehabilitation, provide non-clinical management services. And next slide, Genesis Healthcare. Golden Gate Urology is a physician practice with 12 physicians that provide urology and radiation oncology services to patients in San Francisco and Alameda counties. Golden Gate will transfer certain clinical assets to Genesis and certain non-clinical assets to Unio Health Partners or one of its affiliates. And this was waived just at the end of June. Next slide. Long Beach Commons Clinics Medical Network. This is in review still. Comics Clinic is acquiring the Ambulatory Surgery Center Long Beach from AmSurg Holdings. Long Beach is a wholly owned subsidiary of AmSurg right now and an indirect subsidiary of Ambulatory Topco collectively. And this is, I think, our third AmSurg transaction that we've reviewed. And then NAS Holding. In this transaction, Mojumu will acquire 100% equity ownership of NAHS Holding from the NAHS Employee Stock Ownership Plan Trust through a stock purchase agreement. This is a grandparent level transaction regarding 12 skilled nursing facilities totaling 847 beds located in Sonoma, San Mateo, San Joaquin, Lake, Los Angeles, Orange, and Riverside counties. And those are the last ones we have currently posted in review. We have seen a number of written emails that have come to us regarding new transactions for which we do not have regs in place. And so I'm going to turn to that next. And the next slide. Effective January 1, Assembly Bill AB 1415 amended our transaction review program by adding private equity groups, hedge funds, management service organizations, newly created business entities, and entities that own, operate, or control a provider to the list of entities required to file material change notices of transactions with OCA. Given OCA's transparency mission, we've been updating our regulations with additional information that transacting entities must supply for a public notice, as well as for our review as we determine whether or not a cost and market impact review is needed. With the additional information being sought and based on 2 years now of experience, we're also updating some of our confidentiality provisions. Next slide. In implementing AB 1415, OCA has considered what thresholds and circumstances should be included or excluded by regulation to capture the right mix of transactions for private equity, hedge funds, MSOs, etc. We've added further information to prevent non-duplication of filings based on our practice of engaging with parties over the past 2+ years, as I mentioned before. We are cognizant of the role that real estate investment trusts or other sale-leaseback arrangements have played in the downfall of certain hospitals or elderly facilities and are strengthening our ability to look at that part of transactions, including for a full cost and market impact review. We've also added a procedure to remand a potential CMIR determination based on additional information presented, which could potentially obviate the need for a full process. Finally, we are adding a potential additional reason for requesting an expedited review by submitters based on urgent situations that come. Next slide. So in drafting the proposed regulations, we looked at the Federal Trade Commission merger guidelines and other state requirements. We've reviewed professional literature regarding PE involvement in healthcare, some of which you heard earlier today. We've met with stakeholders for real-world applications. We discussed the AB 1415 implementation at the May board meeting, and we posted a draft for informal comment in May. We received 11 written comments by email, which were posted as part of today's agenda materials, and we also received 1 additional letter later by mail. We discussed the comments to the draft that we received at the June board meeting, and as could be expected, we had some requests to strengthen some aspects of the draft regulations, some requests to lessen some requirements, and some requests for further clarity. And we really want to thank those members and attendees, and especially members of the advisory group, who took the time to review our draft and make thoughtful comments. Our next slide. Our next step would be to finalize the text and then post it online to start the emergency rulemaking process. And we're hoping to have that wrapped up in August. So with that, I'll turn it back over.
Thank you. We'll open it up to discussion, question, comments from the committee. Joan, go ahead.
Really appreciate the update. And it has been incredibly useful to be able to read a lot of those filings. So appreciate even ones where we haven't commented, it has been very useful to be a way to be able to track some of those transactions. And in terms of the some of the updates that you were discussing, appreciate the focus on sale leasebacks and REITs. We've definitely seen cases where REITs end up as active, almost managers of healthcare facilities. And it is often a difficult situation for patients and for workers when that happens. So really appreciate that focus. And did want to ask, most transactions have been waived. How does that play with what you were expecting, and versus what you're expecting going forward?
When we first started looking at the program in general and the initial enabling statute, we also looked to Massachusetts, and we had noticed that they were putting forward, of the dozen that they had done, they had put one to CMIR. And so we said, well, 10% sounds about like that could be reasonable. And we've sent 2 to CMIR of the 45. So we're not at that 10%, but we also have a lot more transactions that were noticed to us that Massachusetts was not getting. So that actually seems to play out about what we expected to.
Thank you. Sean, go ahead.
Thank you for the presentation. I am new to this AB 1415 and CMIR, so please bear with me as I'm not well versed on it. Looking at this, I see some of the consolidations, and it also happens to the other parts of the healthcare world as well. So like looking at like PBMs and GPOs and manufacturers, I wonder if that's also accounted into the healthcare entities. Even so, there are like community-based pharmacies with the private entities acquisitions that happens not too long ago. And, like we also have seen, Rite Aid closures last year, which was almost 350 pharmacies in California, that brought us a lot of impacts on not only the patient access, healthcare costs. So just wanted to bring that up to your attention.
And our statute does have a specific list of healthcare entities. We do not have authority to look at pharmacy transactions per se. We do have pharmacy benefit managers, but if a pharmacy were to be also providing other services, they could fall into a healthcare entity status. But a pharmacy in and of itself would not have to file under this transaction
Just to clarify, pharmacy, whether they are in a health system settings or community-based settings like FQHCs, or even what people are familiar with retail settings, they do provide different type of clinical care services, including but not limited to like immunization, HIV, PEP, and PrEP. Those are falling under the medical benefits. So just wanted to make sure that is also counted.
Yes, we have actually had a number of questions come in through our CMIR inbox, which the public is more than welcome to send questions to cmir@hchi.ca.gov. And that question has come up, do I need to file? I have a pharmacy. And then the question is, well, do you do other things?
Thank you. Andrew and then Suzanne.
Yeah, I guess I have a process question, right? So there was an informal period. You're updating text. Are you circulating for another round of informal comments before it goes to OAL? I'm just trying to get clarity on the kind of just the process, and just given, all of the comments, how are you kind of incorporating all of those into this next version?
We are incorporating the text. We had not planned on going out for another round of comment just because we have people that want to be filing through our regular portal, and we need to update the portal to make that happen, which we need to get the regulations finished to do. But when we are ready to go out and get ready to send it to OAL, we will be posting it online. There's a 5-day period that's required before OAL actually takes a look at it. So it will be online, available for a number of days before OAL begins its review.
So, then do you take those comments during that 5-day period and make modifications? I'm just trying to understand process.
The process can result in changes to text. Yes, it does happen.
Suzanne?
Thank you for this work. I just wanted to first say this is more a comment and doesn't fit really well into the CMIR process. I just wanted to say thank you for doing this. I know a lot of the spirit of it kind of ties back to the beginning of the presentation. We talked about primary care and private equity. Just two other things that I can't recall if we've mentioned in the last few meetings is there's also, not saying it's only private equity, but there's a lot of research now in the last year or two about upcoding, increasing costs. And so if a firm is doing that well, they're able then to turn around and show that as like higher revenue and profit to create more of these consolidations. So that's the only reason I thought of it in this context, because I think we also now have the upcoding might get easier and easier with AI, as will other. I know right now there's a big research in California specifically on fraudulent lab submissions. And since it's an ongoing investigation, I don't want to imply that I think that it is just one laboratory company, but I think most people out there are really trying to do the right thing. So if you're a lab, especially an independent lab, I would say that it's assumed that you're submitting a claim for something that was actually provided, but we are seeing more and more of this fraudulent submissions, upcoding, which would be waste and a little bit of fraud, and just happening at a higher clip. I don't know if it's perfectly aligned with what the intention of this was to make sure that there wasn't a lot of consolidation, which was reducing access as well as driving up costs. But just wanted to say thank you again for at least maintaining the course and continuing to try to search for it.
Thank you. Additional comments, questions? Seeing none from our members attending virtually and no one else here in the room, that'll take us to public comment on this agenda item. If you'd like to make a comment, please step to the podium. If you're attending virtually, please raise your hand. We will go to the podium.
Beth Capel, Health Access. We were the sponsors of AB 1415 to extend the CMIR authority. And we appreciate the question about why so many of the CMIR have been waived, because we did not simply model the authority of this entity on what Massachusetts did. And so a narrow focus on Massachusetts' approach is troubling. We did support expanding the ability to look at private equity because of the ill effects that private equity too often has in terms of higher prices, worse outcomes, reduced access, worse financial outcomes for the entity that has the private equity investment. And so we very much support the transparency in the proposed regulations and the inclusion of REITs, which some of us have dealt with for far too long on the nursing home side and are sorry to see creeping into the hospital side of healthcare. We are troubled that the definition of management services organizations is narrower than the law permits, and have commented to that effect and offered alternative language that is more consistent with the authority in the law, and appreciate that. We very much support the revised provisions on confidentiality, and particularly the plain statement that information which is otherwise publicly available is not confidential, despite what some lawyers seem to think. So we appreciated commenting on the regulations, and we'll look forward to the revised version. Thank you.
Thank you.
Looking virtually, seeing no hands raised, noting for the record, we have about 70 virtual attendees. We'll go back to the podium.
Ben Johnson of the California Hospital Association. Would just like to second, I think, the comments from Andrew on the committee here. These are very complex regulations that are going to extend requirements to a variety of different entities that the state really has limited to no experience in overseeing. And so we do request another opportunity to comment before going to the OAL process in order to see the revisions in advance and offer input before they're probably quite close to finalized in that OAL process. Thank you.
Thank you. Continuing public comment, please step to the podium or raise your hand. Seeing no virtual hands raised and no one stepping to the podium, that concludes public comment on this item. The time is now 12:42. We will take a full 1 hour lunch. To our new members, there's a few restaurants in driving distance, but there's also a lovely cafe downstairs. So we will reconvene at 1:45. Thank you. Well, good afternoon, everyone. Thank you for being on time. We will get started now. I'll turn it over to Director Landsberg to make an announcement.
Thank you very much, Jane. I just wanted to take a moment for a point of personal privilege and thank Jean-Paul Buchanan for his service to HCI and OCA. So Jean-Paul is one of our wonderful senior attorneys here at HCI. He's been with us for 5 years and has been at almost every single OCA board meeting and advisory committee meeting and has served us and advised us so capably. He's worked on every area of HCI's work through his 5 years of tenure. And Bagley-Keene meetings can be messy sometimes because we take it very seriously. We're not like counting our votes ahead of time and figuring things out ahead of time because we can't. And so those of you who have watched board meetings, sometimes they get a little spicy. And Jean-Paul is always here to explain. I think the first spending target meeting stands out as a meeting where there was different motions on the table, and Jean-Paul very, very capably helped navigate through that. And so, Jean-Paul, thank you very much for your commitment. He's taken a promotional opportunity, and we thank you for your service and wish you all the best.
Hey, thank you. We will now get to our next agenda item, spending target enforcement and spending target penalty discussion. I'll turn it over to Vishal Bhagani.
So we introduced this topic to the advisory committee at the April meeting and have since had several discussions with the board pertaining to the topic. We want to bring the committee up to speed. The next slide will provide an overview of what was discussed at the previous board meetings. So before diving into today's conversation, just want to remind the committee about OCA's enforcement process. The law requires that enforcement of spending targets be progressive and include the following actions: technical assistance, public testimony, performance improvement plans, and administrative penalties. All entities who fail to meet the target will receive TA, and then there will be an internal process for determining which entities proceed to public testimony or performance improvement plans. OCA began discussions about progressive enforcement with the advisory committee in September 2025 and has continued these conversations with the board. The topic presented to the board thus far have included a discussion of waiver of enforcement, technical assistance, public testimony, PIPs in January. OCA's proposed approach to monitoring and evaluating PIPs was presented in March. In April, OCA continued the conversation around PIPs and introduced administrative penalties. And from May to June, we have continued discussions with the board on OCA's proposed approach to penalties. OCA is aiming for a healthcare affordability vote to approve the penalty scope, range, and justification factors in late summer. Next slide. So the intent of our discussion with the advisory committee today is to solicit feedback on our approach to assessing administrative penalties. Under the statute, the board shall approve the scope and range of administrative penalties and the justification factors for assessing penalties. The statute also notes that the legislative intent for enforcement is for it to be progressive, and that OCA is supposed to do TA and PIPs before penalties, except for in situations described on the next slide. There is also statutory language about OCA's authority to assess penalties. So this slide details some of the statutory limitations on administrative penalties and penalty adjustment factors or considerations. In summary, if the director determines that a healthcare entity is not compliant with an approved PIP and does not meet the target, the director may assess administrative penalties commensurate with the failure of the healthcare entity to meet the cost growth target. If an entity has fully complied with an approved PIP by the deadline established by the office, an administrative penalty shall not be assessed. However, the director may require a modification to the PIP until the cost target is met. In terms of considerations for penalties, the director shall consider, and it's a list right here, the nature, number, and gravity of offenses, the fiscal condition of the health entity, including but not limited to the entity's revenue, reserves, and assets, and the market impact of the entity. So this slide shares our requirements for consultation and coordination. So prior to taking any enforcement action, and that includes the assessment of penalties, we consult with the directors of the California Department of Managed Healthcare and the California Department of Healthcare Services and the California Department of Insurance. The law also says OCA may consider the provision of non-federal share. So this is the funds that providers put up to receive the federal Medicaid matching funds. So we can consider the provision of non-federal share when assessing penalties, and this could be discussed with DHCS prior to taking enforcement action. And then my last slide covering statute text is this one, which shows what we're calling procedural penalties. So these are penalties OCA may directly assess when entities fail to do any of the following, such as repeatedly failing to file an acceptable PIP, repeatedly failing to implement a PIP, and so on. We'll discuss these procedural penalties in later slides. So when can penalties be assessed? So we went through the requirements in the law. On this slide, we provide clarity on an important question. When can penalties be assessed? To be clear, that's when an entity is not in compliance with their approved PIP and they do not meet the spending target. So that's the first scenario. And then the second one is after repeat non-compliance with their PIP. OCA can assess escalating penalties that exceed the commensurate penalty. And third, when one or more of these violations listed under 12750.2.5H1 has occurred. So those were the procedural penalties that I just described. And today we'll present OCA's proposed approach to assessing penalties in these instances, for which the board will still need to vote on the scope, range, and justification factors. So we'll first discuss spending target penalties, and this slide shows considerations for the proposed penalty structure. The penalty needs to provide an incentive to implement a PIP, so entities will comply with targets. Entities indicate that the penalty statute indicates the penalty should be initially commensurate with an entity's failure to meet its applicable target. Statute enables OCA to consider a number of penalty justification factors to determine the final assessed penalty amount, including but not limited to the nature and gravity of the offense and the entity's fiscal condition and market impact. The range should give OCA the flexibility to lower or increase the penalty from the initially commensurate penalty amount. Escalating penalties must be large enough to deter future non-compliance. And then lastly, entities have multiple opportunities to comply with applicable targets, including through PIP implementation before penalties are assessed. So in light of these, the considerations that I just went over, OCA recommends the following approach to calculate spending target penalties. In step one, OCA would calculate penalties that are initially commensurate with the degree to which the entity exceeded the target. Initially commensurate is the difference between an entity's actual spending growth and what the growth would have been had the entity met the target. And if 2023 were an enforceable year, initially commensurate penalties at the aggregate parent company level for health plans in the commercial market would have ranged from 4 million to 350 million. In step two, excuse me, OCA would then consider a variety of justification factors that could result in an increased or decreased final penalty amount. Penalty justification factors are the ones that I mentioned: nature, number, and gravity of offenses, fiscal condition, and market impact, and then consideration of provision of non-federal share. Other potential adjustment factors include input from other state agencies, other factors approved by the board, and escalating amounts for repeated failure to meet targets. So this next slide just provides an illustrative example. Again, the board would need to approve both the scope and range of penalties. OCA recommends a percentage-based range up to 125% of the initially commensurate excess growth. Shown here are examples of penalties calculated at the maximum of the range. In the left, we show commensurate penalties, which equate to 100% of the commensurate penalty. So these are the figures that I just referenced for commercial plans had the target been in place in 2023. And then in the columns to the right, we have a non-exhaustive list of examples of what the initially commensurate penalty would be if it were increased to a maximum of 115, 125, and 150. And just as a reminder, OCA's recommendation is that the range be up to 125% of the commensurate penalty. And then moving on to penalty justification factors, the board must also approve penalty justification factors. OCA recommends penalty justification factors that I've articulated before. It's these 4 factors here. And then I'll walk through some examples on the next slide. So during the board's discussion, there were questions about what the penalty justification factors might include. So this slide shows an example, a non-exhaustive list of potential examples of each factor, of what each factor could include on a case-by-case basis. The left column shows what is listed in statute, and the right column shows what that might allow OCA to consider. For example, for the nature, number, and gravity of offenses, we could consider excess growth beyond the state average or excess growth that was an extreme outlier, excess growth due to investments in primary care, and more. For fiscal condition of the healthcare entity, we could consider bankruptcies or other legal proceedings, whether the proposed penalty negatively impacts the entity's financial standing with other state and federal regulators, and more. And lastly, for the market impact of the entity, we could consider if the entity's share of total covered lives statewide is significant or greater than the average. We could consider the entity's impact on spending in its county, and more. So this slide shows a few clarifications about how OCA would implement spending target penalties. We would enforce each performance year individually and discretely. OCA would assess a penalty against the performance year that prompted enforcement. OCA could assess penalties against an entity for missing PIP milestones. So this next slide shows how OCA would enforce each performance year individually or discretely. This graphic shows annual enforcement. The dates here are approximate and for illustration's sake to show how PIP durations could vary. Additionally, the start and end dates of the PIPs may vary. But the takeaway is that an entity may potentially be subject to financial penalties for each year of non-compliance with the target. So looking at the first row showing 2025 to 2026 spending year, let's assume an entity exceeded the target in 2026. The data is reported in September of 2027. If OCA determines that a PIP is warranted, a PIP would be developed late fall or winter 2027. Excuse me, a PIP would be developed from late fall, taking place around late fall or winter 2027 until spring/summer of 2028. This would include the time entities have to develop the proposal, the time OCA needs to review, discussions with the entity, obtaining board input, as well as input from other regulators. So if we assume it's a 2.5-year long PIP, it could begin in July of 2028 and end at the end of calendar year 2030. At the end of the PIP, OCA would determine if the entity was compliant with the PIP and whether the entity came into compliance with the spending target. If they were not compliant with the PIP and did not come into compliance with the target, a penalty could be assessed in 2031. And then going on to the next row, this is the spending year for 2026 to 2027. We see the same process play out. If the entity exceeds the target in 2027, the data would be reported in September 2028. Here, the entity is implementing a 1.5-year long PIP. And here we assume that the entity was not compliant with their PIP and they did not come into compliance with the target. So a penalty could be assessed for 2027. And then, the last row here for the 27 to 28 spending year, we could see the same process play out. And lastly, I do want to highlight here, as we see in the example enforcement timeline, that spending target penalties would only be assessed after entities have been given an opportunity to improve their spending performance. And there's going to be a lag due to timelines surrounding data collection and PIP implementation. Entities would have multiple opportunities to make improvements before penalties are assessed. So just taking us to our last slide before we go on to procedural penalties. So I want to review some highlights from the board discussion pertaining to spending target penalties. Board members shared concerns about entities being able to grow from a higher baseline once they've exceeded a prior year spending target. We did clarify with them that healthcare entities will be subject to enforcement for each year they exceeded the spending target. Board members recommended that PIPs require milestones so that OCA could better monitor for PIP compliance and assess penalties for non-compliance with PIP milestones. OCA clarified that PIPs could require milestones and that OCA could assess penalties for missing a milestone. Board members shared concern about OCA's ability to bring entities into compliance with the target when entities comply with the PIP, with their PIP, but still exceed the target. We noted to the board that the statute prohibits spending target penalties for entities that comply with the PIP and exceed the target. This means that PIPs must be sufficiently designed to address the causes of excess spending. Board members discussed the meaning of the statute's penalty justification factors, with particular focus on market impact. We clarified that the existing statutory language would allow OCA to consider a wide variety of factors and that the board could add more specific factors later if the need arises. And then lastly, the board members, some members shared concerns that a range maximum of 125% may not be high enough and that the exact minimum should be stated. OCA clarified that the board could adjust the range in the future if the need arises. So I know I covered a lot of content, so we'll pause here for discussion of spending target penalties. Specifically, we're looking for feedback from advisory committee members on the 3 items listed here. So the first one is a penalty structure that calculates penalties that are initially commensurate and then makes adjustments based on a variety of factors. Penalty justification and 2 penalty justification factors, which would be those listed in Health and Safety Code section 127502.5D and was covered on a prior slide. And 3, a spending target penalty range of up to 125% of the initially commensurate excess spending growth. I'll turn it over to Jane to facilitate discussion.
All right, discussion comments. I'll start with Stephen.
Building a bit on the suggestion this morning, it would be possible to think about it and for the board to think about in the PIPs, for example, using data that's available, and it could be added to justification as a justification factor or built into a subsequent penalty, discount on the penalty, whatever it might be. Talk about changing the behavior. What's going to motivate changes in the behavior and the underlying business models? And so as suggested, one example, these are just examples, of looking at the percentage of revenue or whatever the denominator might be that is away from fee-for-service payment. So we have targets, for value-based payment models. So consider using those, kind of connecting the dots among the various activities that OCA is involved in, and give hospitals, medical groups, or whatever credit if they're moving towards, and you can use the data to set, right? They're moving towards payment models that reward prevention, promotion, keeping people out of hospital beds when they don't need to be there, et cetera, et cetera. And you have the quality metrics as well. Or the percentage of patients being served and whatever for a medical group that are in accountable care organization models, right? To be, using the LAN 3 and 4, Learning Action Network payment models would be another example. And so maybe they're not hitting all aspects of the performance of the PIP, but if they're hitting some of these targets and you make them stringent or not so stringent, then, perhaps they don't get as much of a penalty, or you count that they've met their PIP if they're hitting these kinds of targets. The causes of the spending, yes, but the causes aren't necessarily going to change the behavior. So it's looking more at what's going to change the business models, how organizations make their money in a way that is promoting short run, long run, more affordable care, more incentive to innovate. We heard one example from LA General this morning about an innovation as an example, and inducing or motivating more of that kind of behavior. So that would be the suggestion. I can elaborate on that if you want later. And to have the OCA board consider that, and if there's time between now and then where you have the data through HCI to kind of see what some of those numbers might be. I don't know if you have all the data you need. I think you have some of it, though.
Good. Yes, Iftikhar. Sorry.
And a second question, I think David had originally brought that up and I didn't see in the timeline. That's why I'm asking again. So if after the data is submitted, if you find that 350 out of the 400 hospitals in California did not meet the standard, would you do anything differently than say if only 5 had missed the standard? Because there's 2 questions. Number 1 is the effect on access. If most hospitals are missing the target, it would have a disastrous impact on access. The second is your own capacity to handle the PIP process. Like what is the bandwidth to be able to handle hundreds of hospitals going through a PIP process?
Yeah, there are hundreds of hospitals. There's dozens of health plans, similarly for medical groups as well. So we can't put everyone on a PIP. So we do have those enforcement considerations, which we've gone over before. So we could look at certain factors like historical spending growth, your baseline costs, and then we could we're going to have a way to prioritize which entities we take to a performance improvement plan. And then your first question was about yeah.
Oh, yeah.
Can we really impose penalties and financial hardship on so many hospitals?
So they would need to go through a PIP first. They would get TA, a PIP, before we assess a penalty. And then one of our penalty justification factors is the fiscal condition of the entity. So if a hospital is in distress, or would have a significant impact on the community they serve. So those types of facts about kind of the circumstance of the hospital could be taken into account at that phase.
So one thing that could happen is that the capital plan and planning is years in the forward making. So I think if you have, as a CFO of the hospital, if I knew that such a large penalty was on the horizon, I would stop all capital spending, so there would be immediate impacts in anticipation of a possible penalty, knowing that the penalty may or may not happen.
I don't know if I have a answer to that. I think that's just more of with any kind of state or federal policy that there's. So you're talking about the OCA penalties for planning. Yeah, it's a little speculative, so I don't know. And it's a hypothetical too, because we wouldn't. We have certain steps we have to follow before we assess a penalty.
Point was a threat of penalty will impact that behavior because you would have to plan for that big cliff when the penalty hits.
Yeah.
Okay. Andrew, and then Joan, and then David, and Michael.
Yeah, so Vishal, just on the calculation of excess spending growth, right? Just quick example. So let's say 2026, right? There are factors that, I would just say there was a fertility mandate that went in for 2026. That's worth maybe 2 point something in that neighborhood. And then you have labor adjustment after the fact. So I guess if let's say our target is 3.5, right? So if after you adjust for the fertility mandate and the labor thing, you end up with a number closer to 6, and then the entity comes in at 6.5. I'm assuming the excess is just 6.5 minus 6, right? You would actually adjust after the fact, and the calculation of the excess will take into account all of those after the fact factors. Yeah, just for the calculation of the excess part, right? So I think, everybody will submit their data, right? Everybody will offer justifications as to why they didn't hit the 3.5. And part of it is going to be a state mandate. I can just tell you now, part of it's going to be a state mandate that went in this year. Part of it is going to be the labor adjustment after the fact. So it's really a calculation of how are you calculating the excess.
Yeah, that's where those types of situations would be considered in the penalty justification factors. So the nature of the offense. So things like changes in state or federal law that are impacting spending, those types of circumstances would be taken into account then. And we would ask for data information to substantiate what was driving excess spending.
So just to make sure I'm tracking, Andrew, so if you're asking if the calculation of the initially commensurate would take into account a benefit mandate initially, the answer is no. It would be later as part of the justification factors.
Yeah,
right. But
the step one was the initially, that's just the difference. And then step 2 is where those adjustments could be made.
Oh, it's interesting. Okay. So yeah, no, I'm just starting to think through, right? Because if you look at page 59, right? So that kind of maybe it probably is probably need to kind of really lay out the timeline on 2026, right? Because you have all the pieces now from data submission, and then there's usually a back and forth on the data. And then I'm assuming there's a process on justifications on, yeah, we missed the 3.5. Why did we miss the 3.5? And then TA, public testimony, PIP, all of that. Maybe it will benefit everybody to have kind of a clearer timeline. Just because I think what you have on the page may be a little tight, just given the number of steps in the process.
So this is like once it's covering within this exceeding the target, there is that 45. This is kind of assuming that 45-day period where they give additional data information that's done, and we're moving them on to a PIP. So this is what this timeline is showing.
Yeah, but I think, Michelle, we probably need a fuller timeline that has all the steps.
Okay.
Because this one kind of just, there's a break, right? You had a better chart from last time that has like this, it's almost like a.
Oh, you're talking about the boxes.
Yeah.
Okay. Yeah. We have that.
All right, I've got Joan, David, Michael, and then Cassie.
We've got, so on this slide, we've got under number 2, I think really helpful descriptions of some of the potential justification factors. And wanted to drill down a little bit on 2 of them. And then comparing that to the earlier slide where there also was the same list of 4 of them, and then the sort of examples. And on the fiscal condition, there's a little bit of a mismatch in how it's framed. So if you skip back to slide, it's 57 in our deck. I think it's 58 in this deck. Yeah, that where the fiscal condition focuses much more on just the entity and on potential negative impacts. Whereas the other description, which is also one slide back, it's in 2 different separate slides, focuses on the entire system. And I think that focusing on the entire system is a more helpful example here than just the entity's revenue, profit, assets. Because the other slide says fiscal condition of the healthcare entity, including all of those, as well as affiliates, subsidiaries, other entities that control, govern, or are financially responsible for the entity, or are subject to the control, governance, or financial control of the entity. And I feel like that framing should also be here in this list of potential examples. Would be a helpful addition, because otherwise it frames very much as almost, well, we shouldn't penalize because the first 2 bullets are about it potentially negatively impacting, as opposed to this is an entity that absolutely is not only exceeding their target, but also just bought a hospital system out of state and has $10 billion in reserves. And so just balancing that framing a little bit with the framing that's already in the other slide. And then on the market impact of the entity would suggest also reflecting that the penalties are assessed by market segment. And so market impact could also be usefully flagged here by market segment.
Thank you, David, and then Cassie, and then Tam.
I'm just going to maybe hammer home a bit more what Andrew was saying. So in my opinion, I'm going to keep it simple, but if 3.5% is the target and the IVF mandate adds 2% on top of general inflation, which I think is going to be about right? That's a state mandate where more healthcare is consumed because of a state mandate. It'll be direct IVF treatments, and we're already seeing more evidence of more premature births because more, unfortunately, every IVF comes with a higher risk of a NICU baby. So from the point of view of a provider, you've got underlying healthcare cost inflation, plus this new stuff that you're now paying for, that you're providing to patients, which increases the healthcare costs. So in my opinion, if that means the net increase adjusting for the IVF means it's 3.5 plus 2, that's 5.5%. And then that's the underlying trend. And then maybe the healthcare provider is 6.5% trend. In my opinion, the penalty should only be that 1% delta between 5.5 and 6.5. To assess the penalty on the difference between 3.5 and 6% there, I think is just wrong, because you're now penalizing a provider for complying with state law in something that's out of their control. And I know you're saying, well, maybe we might adjust the penalty, but I think it's wrong. I think the notion is the penalty should only be assessed on the difference between the underlying cost growth target and uncontrolled components, and maybe you add labor to this as well, and then the actual trend. But to ignore that and set a penalty that's the entire delta, I think is just, in my opinion, is the wrong way to go. I know maybe the board's already approved this, so I'm wasting my time, but in my opinion, that's the way you should do it.
Cassie?
I think my comment is in a similar spirit to the previous one. I know this is not for discussion today, but what an outlier is, I heard that earlier, but I do think when you think about that penalty amount, and you're comparing to 3.5, it may be easiest or, most effective to compare to like a market average. And for the outliers, because the market average would include any events that happen. So the IVF mandate would be an example of a mandate, but there could also be expanded, life-saving cures invented, right? Like gene therapies and expansion of gene therapies. That would be a market event that would impact everybody, that, should be taken care of when you calculate the penalty. Additionally, I don't understand the order of operations between, so if I work for a health plan, so I have a health plan perspective. If I have a PIP, but then also several health plans that I work with and contract with have a PIP. Right now, the way this is written, there'd be double counting in the penalty. And it would be much more than what the actual total miss was between the combined efforts that we're all working on, and so the order of operations of the health plan ultimately is paying the provider for their miss. Who gets penalized for that?
Thank you. Tam? Oh, I'm sorry. Excuse me.
Oh, yeah, just a follow-up question. You said the health plan and other health plans, or did you mean providers?
I meant providers. Thank you.
Okay.
Yep.
So each payers are held to a target, like payers, hospitals, and physician organizations are all held to the target. Each one will be evaluated for did they exceed the target. And there could be different reasons why they're exceeding the target. So, and then they each have different levers in what they do within each market. So, just wanted to make sure I'm understanding what you're saying. You're saying, like the health plan overall is paying for care, but then its contracted providers, including its hospitals and medical groups, are also on a PIP.
Yes. Yeah.
Okay.
So if we're collectively all on a PIP, the health plan if the health plan is exclusively, this is an extreme scenario, but if the health plan or the payer was exclusively contracted with systems that are on PIPs, that health plan is going to miss the target, right? That the math would have to work that way. And in that scenario where there's exclusive overlap and there's full overlap of those systems, the way this is calculated is the penalty, the revenue from the penalty would be much greater than what the source of the miss is. Does that make sense?
So the revenue,
well, I'm calling the penalty of up to 125% revenue That may
Yeah.
not be the right way to describe it, but the penalty would add up to more than the source of the miss.
Okay.
Michelle, I'll just say, look, if Blue Shield had one provider underneath it, right? Hill Physicians Medical Group. Hill Physicians exceeded its target by $5 million, say, and we have to pay a penalty on that. I think her very good point is then Blue Shield would also exceed their target and they would have a penalty too. So you have doubling up of penalties for the same cost variance, which hits Hill and Blue Shield.
All right.
Because what they pay is what we provide.
Thank you.
So
That was much more clear than how I
is-
described it.
Okay, is the assumption that the penalty is passed on to the payer? No, okay.
You're double counting the
Okay.
penalty.
We hear the point. I mean, that is the way the statute is designed, is that the requirement to not grow more than the spending target is on each of the entities. I understand that a hospital and a medical group spending relates to the health plan spending.
But you could adjust your factors to include the fact that you want, from a policy standpoint, want to avoid double counting penalties between providers and plans.
We hear the point. Thank you.
Thank you. Cassie, did that conclude your comment or question?
Yes, thank you.
Thank you. Moving on to Tam.
I wanted to focus in on the initial penalty and encourage OCA to ensure that it serves as like a starting point for the analysis rather than effectively determining the outcome before the adjustment factors are applied. And so some just suggestions here is to consider other approaches to establishing the initial penalty amount, including using penalty ranges or graduated tiers based on the degree of noncompliance, or establishing reasonable maximum penalties that align, the penalty with its intended function to incentivize entities to meet the targets. I also wanted to note that the statute requires penalties to be commensurate with the failure to meet the target, but it does not require the penalties to be directly proportional to the excess spending growth. And so, the statute directs the director of OCA to consider, other factors, including the nature and gravity of the offense, the entity's fiscal condition, and market impact when determining these penalties. And so we just encourage you to take, another look at this and see if there are other ways to approach that initial penalty amount.
Thank you. Additional comments, discussion? Yeah, Michael?
Sorry, just in terms of public visibility. So as an entity would cascade through this process, is it all publicly visible? Is that part of the statute, everything? So entity A exceeds its target. Does the amount by which entity A exceeded its target get publicly announced, or first? Secondly, they go through TA, they maybe have a PIP. If they have a PIP, is that PIP publicly announced? If they're non-compliant with the PIP and there's a financial penalty potentially on the table, is that publicly announced? Is it all concurrent? Is it sequential? And is it all visible to the public?
It's more sequential, and we're required under the law to provide a list of entities that have exceeded the target and the extent to which they exceeded the target. And then if somebody's on a PIP as well, to publicly disclose they're on a PIP, and then also provide detailed summaries of progress on the PIP to the board. And then we're still planning to have some conversations about kind of what is public and what is not at upcoming meetings as well.
Thank you. Others? Mike?
Yeah, so just to confirm what you just said, the PIP itself is not necessarily public. Like, is that what you're still having discussions about that, or?
Yeah, the law only requires a detailed summary of the progress on the PIP and the entity's compliance with it. But we're still evaluating kind of what additional information we could put out there about the PIP.
Is there an assumption of so there's no assumption that the details of the PIP itself would be disclosed to the public, or I mean, if there's, and the discussions before the board would all be public. It seems like those wouldn't be private sessions.
That depends. There is authority to do closed session to discuss PIPs.
Okay, right. Yeah, I think yeah, I mean clearly this is a discussion about how to target how to decide what the penalties should be, but one element of changing behavior is public accountability, and I think to the degree that there is these things are publicly disclosed, and nobody wants to be put on a list as being a high-priced entity, or a hospital, or a high overpriced insurance plan. So to the degree that those things are made public, I think you might find that there could be some changes in behavior, because there would be a cost to that being publicized. So it's an additional sort of non-monetary way of moving the needle, perhaps. And then I just wanted to echo Joan's comment about making sure that the entity's relationship with its system ownership is a part of the analysis as well, just is because that is a lot of the wealth of the some of these larger organizations is contained at the system level, and and many of these organizations are tax exempt. They're not paying taxes, and they're taking a lot of that tax savings, and rather than dumping it back into providing care more cheaply, they're putting it into these investment funds, and that grow exponentially over time, and so there's just these massive pools of wealth out there that have been generated through all this cost growth in healthcare, and that really needs to be a part of the discussion when looking at this. Thank you.
Thank you, Joan.
Just bringing the PIP conversation back to some of our earlier conversations about it, and some that's been discussed at the board. Just wanting to make sure that there is some kind of transparency around that requirement, that a PIP not be approved that would erode access, quality, equity, and healthcare workforce stability. And if that's the place for transparency, would certainly appreciate that.
Thank you. Iftikhar?
Just kind of reminding people that under accrual accounting, if it's not a cash basis accounting, it's an accrual accounting. So as soon as there's a likelihood that the penalty will be imposed, it would have to be recorded. And if it's recorded, it may pose a debt service violation. It may trigger all kinds of events. Certainly a disclosure in the financial statements that could then trigger, even if the penalty is eventually reversed. So just keep that in mind as we start this process.
Thank you, Kieran. And then David. Try the microphone. Let's see, closer to the mic.
Sorry. And I feel like we discussed this last time, but I might be losing my mind on the PIP timeline, because it just seems very long when we're sort of considering the annual impact that consumers are seeing here. So is there sort of an idea that the PIPs would contain interim milestones that need to be met, and that there could be penalties assessed if those milestones are not met? So, because there are some things an entity can do really quickly, like a easy example is reduce executive compensation, like they could do that tomorrow, right? And there are other things that take more years that could be part of a PIP. So is the idea that it's sort of you do the entire time period and you assess the full PIP, or that there are milestones and potentially associated penalties within the time frame of the PIP? Does that make sense?
Yeah, we would want to see milestones in a PIP and then monitor those, because that's kind of a way for us to manage and monitor the entity for compliance. But the goal is to kind of give them the opportunity to fully implement the PIP. But we do have the authority to levy penalties if milestones are missed. And there's kind of a lack of cooperation. So we'll be going over those procedural penalties shortly.
Thank you, David.
Joan's comment may be very uncomfortable because as a provider, if I'm facing a situation where I need to reduce my trend, many of the things that she listed are maybe some of the things that I would have to do to reduce trend, reduce programs, reduce expenditures, payments to labor, etc. So I'm worried we get into wishful thinking here. We think we can wave a magic wand and get the trend low without making any actual impacts. There will be impacts to healthcare providers reducing their trends. So I just want to say that clearly.
Thank you. Okay, seeing no additional comments, questions, discussion on this first portion of the agenda item, we will continue on with this agenda item, and then at the end, we'll take public comment.
Thanks for the discussion on spending target penalties. We'll now turn to what we're calling the procedural penalties for those violations listed under Health and Safety Code Section 127502.5H1, or as we also like to call them, the H1 penalties. We'll show those violations again on the next slide, but considerations for these procedural penalties include that they should or need to allow OCA to respond to non-compliance with enforcement actions, including public testimony and performance improvement plans. Procedural penalties should encourage entities to participate in the enforcement process, and procedural penalties can be issued in addition to spending target penalties depending upon an entity's compliance with the enforcement process. Taking us to the next slide. So this slide shows part of what OCA is recommending for procedural penalties. The left column lists the penalties outlined in statute, and the two columns on the right share OCA's recommended approach for calculating the penalties. For B, C, and E, OCA is recommending a per day penalty. For D and F, OCA is recommending a flat penalty. And for A, the board has approved data submission penalties. These could be further refined or modified in the future as well. But we're going to focus on sections B through F for today's discussion. In the following slides, we'll share more details about these recommendations, and we'll pause for a discussion. So this slide shows more details about OCA's recommendation for repeatedly neglecting to file a performance improvement plan or an acceptable performance improvement plan, or knowingly failing to provide required information. OCA's recommendation for these violations is a penalty of up to $10,000 per day. Here, repeatedly is mentioned twice, and repeatedly means not filing a PIP or failing to file an acceptable PIP more than once. And a few notes about this recommendation are that depending on the entity's compliance with the enforcement process, spending target penalties may still be issued in addition to the procedural penalties. A per day penalty prompts entities to take action to prevent penalties from continuously accruing, and $10,000 per day aligns with other programs. Go to the next slide. So here we have OCA's recommendation penalty amounts for repeatedly failing to implement a PIP and knowingly falsifying required information. OCA's recommendation is a one-time flat penalty of up to $500,000 for these violations. Here, repeatedly means failing to implement a PIP more than once, which could mean failing to implement more than one component of a single PIP or failing to implement multiple PIPs over an extended period. Depending on the specific facts of an entity's compliance with the enforcement process, spending target penalties may still be issued. A flat penalty is appropriate for these violations because OCA is no longer seeking to compel an action. The entity has already failed to implement the PIP or has already falsified information. A flat penalty of up to $500,000 a day aligns with the Massachusetts approach for entities that do not implement their performance improvement plan. So here we'll review highlights from the board discussion on procedural penalties. Board members shared that a flat penalty of $500,000 for falsifying information may not be high enough. OCA, we said that we would consider said feedback. Board members asked that language for the procedural penalty for failing to implement a PIP clarify that the penalty targets healthcare entities that do not attempt to implement the PIP rather than those that attempt to fail but achieve the PIP goals. OCA responded that it would consider said feedback. A board member asked for clarification on whether OCA could proceed to assessing a spending target penalty if an entity is refusing to participate in the enforcement process. We indicated that we would follow up, though OCA could pursue spending target penalties for those penalties that do not participate in the enforcement process. So here we'll pause for discussion and see if the advisory committee has any initial feedback on the proposed procedural penalty framework. Specifically, that's a penalty of up to $10,000 per day for repeatedly failing to file a performance improvement plan or an acceptable performance improvement plan, or knowingly failing to provide required information, and a one-time flat penalty of up to $500,000 for repeatedly failing to implement a performance improvement plan or knowingly falsifying required information. I will now turn it over to Jane for discussion.
Okay. Comments, discussion, questions? Stephen?
On slide 66, the middle bullet, I guess, a board member asked about this. If I'm understanding it correctly, I think it would be difficult to determine the difference between an entity that makes no attempt to implement versus those that attempt but fail. So I would just suggest you keep, that applies to those that fail as well. I mean, maybe there's a way to determine never made an attempt versus attempted but failed, but I'd be interested to hear what that, you know what I mean? It's like, so I would just suggest with the original language, I guess. And a second, I mean, right. And on the 500,000, if some people feel that's not enough, you want a rationale for why it should be higher, maybe $1 million. You might do that on total revenue or the size of the reserve, the size of the system, you have more deep pockets, and to deter them, maybe we should go to $1 million. But I'm not suggesting that, but you just want to have a rationale if some people feel that strongly, or over time, the 500,000 turns out not to be enough.
Thank you. Ken?
Yeah, following up on Steve's comment, the question for the $10,000 is both in B and C, it suggests intent of not complying. And I wonder if even 10,000 is enough to change that type of behavior, unless I'm not reading this correctly. Repeatedly neglecting to file a PIP, repeatedly failing to file an acceptable PIP. The intent is to obstruct what you're trying to do. So I think as high a penalty as possible should be imposed to change that type of behavior and not reward the bad behavior. And as far as the one-time penalty, I agree that, 500,000, $1 million, I don't know what the number is that would be enough to really change that type of intentional behavior.
Thank you. Sarah, and then Karen.
It sounds like the 10K and the 500K, there's some precedent for choosing those numbers, but I'm wondering what has been the outcomes in the real world? Have those penalties changed the behaviors of those companies that have accrued those penalties? I think one was Public Utilities Commission, and I forgot what the other one was, Medi-Cal Managed Care. And also, I think others have kind of mentioned something like this, like determining almost some sort of sliding scale for penalties dependent upon factors like the reserves of an entity. Because, I mean, this is just one of those things that you hear people talk about, but like the cost of doing business. So, making sure that we aren't continuing to just implement penalties that aren't really effective.
Thank you. Karen, and then Suzanne.
I think mostly ditto to what I understood of Ken's point, like that these penalties are so much lower than the potential penalty assessed if you do receive the information and the entity is out of compliance, has exceeded the target, that I'm not sure why. If with penalties of this size, it feels very, I feel like it incentivizes potentially trying to game the system for entities, which we want to avoid. So I would encourage rethinking these.
Thank you. We'll do Suzanne, Carolyn, Barry, and then David.
I think this is a progressive or question on the progressive comments about what was talked about before is what I'm thinking ACA penalties. So at the ACA penalties, it became a risk-based decision to say either I pay the $11,000 per employee per year to offer the coverage or the $6,000 penalty. So I'm happy to pay the penalty because it's half the cost. So some of that is the dollar amount. So I don't have a comment on that because I kind of agreed with everybody else. But some of that is enforcement as well, because then the IRS quickly on those documents said they would directly affect their taxes. So they wouldn't be able to take as many credits. They were connecting it back to the other items. So I guess the actual question in there is there for the other items, or maybe for this presentation, is there recourse for non-payable penalties, non-paid penalties?
Yeah, if penalties aren't paid, then our attorneys would go through the judicial system to seek those.
Carolyn, then Barry, David, and Sean.
Thank you. I think we're seeing some consistency here in our concerns. And, I'm a licensed insurance agent in 7 states, and I'm looking at personal penalties if I misbehave that are way stiffer than what I'm looking at here for corporate level behavior. And I'm thinking, I agree. It's almost like we're rewarding not doing what you're required to do, because we're hearing comments. I've been gaming this too. I have personal clients where they didn't bother to do the ACA insurance requirements because it was cheaper to pay the penalty. So I'm like, if we don't send a very strong message about this is not acceptable, they will absolutely game the system. Individuals game the system. So why wouldn't a corporation? This is like a slap on your finger. This is not a penalty.
Thank you, Barry, David, Sean.
I want to understand on that second bullet of the second sub bullet of the first bullet, a $10,000 fine per day for failing to file an acceptable performance improvement plan. So does that mean, for example, that if included in the performance improvement plan among 5 or 6 things to get from a 7% year over year to a 3.5%, they're proposing to close a service or close a program, OCA can say, you know what, we think you need that program. We refuse. So it begins to tick up 10,000 a day. Or to make it different, maybe they're going to implement a proven AI tool to handle some of the administrivia that happens between health plans and providers, and it might replace some positions. We don't like that. It impacts workforce. Or we're going to implement ambient listening to make the doctors more productive. It's been shown all over the country that that can be effective. We don't like that. It might burn out doctor. So is that the kind of thing that could go the back and forth in terms of, and it's clicking $10,000 a day because we haven't, or am I interpreting it incorrectly?
No, these procedural penalties are more about lack of cooperation. So if we're having a dialogue and kind of just we're trying to approve a PIP and then there's still some back and forth and we still haven't reached an agreement or an approval, then those penalties wouldn't kick in. This is really if we're waiting for information.
There's not a productive dialogue going on. Okay,
yeah.
Okay. Thank you.
I could be proven wrong, but I would be amazed if providers would not engage in this process. It's a highly visible process, very public. I think as a provider, I would be amazed if people would ignore this. My advice would be, a lot of suggestions here, make the numbers bigger. I think make the numbers bigger if you don't get compliance. I'd be very surprised you don't have basically 100% compliance with this, personally, because of its visibility.
Sean and then Kim.
So I'm walking through the process of like what happens, but it's kind of hard to picture it without knowing how the PIP looks like. Um, Certain things that gets me is like once that entity has to develop a PIP and have to streamline or restructure in order to contain the overspend, and they'll make a decision on like any ways to streamlining their structure, right? So if we are looking for the outcomes that helps with the patient outcomes or better way to reach the population and the accountability, it may actually derive a some consequences that we haven't really thought about. So that's a little bit concerning. So is there a certain element of PIP that requires, it won't be, one size fits for all, but like, do you guys have a certain guidance or elements that provides to the entities?
Yeah, in the PIP guidance, we ask entities to identify kind of things that may hinder their ability to implement the PIP. Other things for them to monitor for unintended consequences on access, quality, and workforce stability, and for them to include balancing measures that they could monitor as they're focused on the cost reducing efforts. So that that'll be in the PIP, and then OCA would receive progress updates on compliance with those elements.
Because potentially they could reduce the workforce to contain the cost, or finding somewhere else to cut the cost to contain it, and may result in unintentional consequences.
Yeah, there's a requirement that PIPs don't erode access, or the director shouldn't approve PIPs that are likely to erode access, quality, and workforce stability. So those conversations would be happening with the entity, prior to them developing it, and then we'll have that dialogue to make sure that those initiatives are in compliance with the requirements under the law.
Thank you.
Ken?
Yeah, I think given the comments here, I respect David's comment from the standpoint that you'd like to think nobody would want to be on the wrong side of something like this. But as we see in day to day in this country now, there are entities and people that do whatever they want and just never feel they're going to be held accountable and don't have to change. So in that regard, I would almost say $100,000 a day and $5 million would be an attention getter.
Jail time.
Eugene Carroll will donate.
All right. Any additional? Yeah, go ahead,
Well,
Ken.
One other thing is it possible, this is on the serious side, is it possible for the director to be given the discretion to impose a minimum and then up to a maximum? Keeping in mind a determination as to intent.
We're interested in having a uniform approach that we start with.
Thank you. Joan and then Katina.
Following up also on David's comment about the likelihood that we get very strong compliance because this is a public process. What is the transparency around procedural penalties?
Assessed.
Yeah.
Yeah.
Will we know if someone's racking up $10,000 a day?
Yeah, we'll have to take that one back. We do have some other items related to the PIP and kind of what's public disclosure pertaining to the PIP. So we'll take this question back.
Appreciate that, because it does impact sort of that that aspect of how impactful the fines are.
Thank you. Katina?
Yeah, thanks for this discussion. I've been vacillating kind of back and forth about this in terms of just the amount of the penalties. Can I ask just for the one-time flat penalty of up to 500, is that one time ever or one time in a certain time frame?
One time per violation.
Okay, and then the PIP implementation timeline is sort of over 2.5 or 1.5 to 2.5 years, depending on when it occurs. For those who are like the D failing to implement and they sort of are just taking this $500,000 fine and just paying it because maybe it's cheaper, is there some way to fast track them to the spending target penalty, which would be higher?
Yeah, these the procedural penalties could work. They could be on top of, or both could be occurring at the same time. So you could have some procedural penalty violations for not for failing to implement a PIP, and then the exposure for this. Then there's also exposure for the spending target penalty, which would begin at an initially commensurate amount. And then earlier you referenced kind of a 1.5 to 2 year PIP, like this under the statute, a PIP could be implemented up to 3 years, but it'll depend on, each entity and kind of how much time they need to implement the strategies they propose.
Okay, thanks.
Any additional Nancy?
Hi there. I know I'm new, so this may have already been covered, but I would appreciate, I don't really understand what technically can be exposed about the PIP. I understand that the PIP process is behind closed doors, but I would like to have a fuller understanding of what can be publicized over the lifespan of a PIP. So the initiation of a PIP, I understand the actual PIP itself is behind closed doors. If there are violations along the PIP process or failures with the PIP process, how much of that can be publicized? Also, conversely, if someone is complying with a PIP and like maybe someone doesn't take 2.5 years to complete their PIP, like is that information available to us? And that may have been covered in an earlier meeting, or if it has been, if someone can point me to statute, I'm happy to do some reading, but I'd be curious to know about that. Because I also feel like I think Mike might have raised this initially, the court of public opinion also, has a cost with it. And I think when I think about fines, that feels like it might influence some of the consideration of amounts of fines. Thanks.
Thank you.
There was a question. You had a question, right?
So my question is where, if someone can point me to where that information exists, or if it's already been shared with the advisory. Yeah.
We're actually, it's a good question, Nancy. No, you haven't missed anything. We're still developing our approach as to how public the PIP and the PIP process will be. So that we'll have a continued conversation about that. Right.
So I'll just go on record as saying I think as much exposure and as transparency as possible is useful. And I think when I look at the history of audits, for different types of compliancy issues, it seems like when there's some sunshine sometimes on that there has been a different level of activity. So I don't want to name any specific cases, but when I look at like kind of the history of activity in our state, it seems like sometimes with more transparency, there can be more compliancy.
Thank you. We've definitely heard an interest in transparency on that.
Okay, any additional comments? Questions? All right, that concludes discussion on this portion, or are we at the end of this agenda item?
So our next steps are a board vote on spending target, penalty scope, range, and justification factors for Health and Safety Code sections 1275025 A and D, and then the board vote for procedural penalties, scope, range, and justification factors for the H1 penalties that we discussed in the latter part of today's presentation. And OCA staff would then draft regulations for spending target enforcement and penalty assessment.
Right, that concludes this agenda item. We will now take public comment on this item. And as this is the last agenda item, we will take general public comment also. Please step to the podium. If you're attending virtually, please raise your hand. Seeing no virtual hands raised, we'll go to the individual at the podium.
Bill Barcelona with America's Physician Groups. APG appreciates OCA's thoughtful work on the progressive enforcement framework to date. We appreciate the meetings that we've had with staff. One of the underlying policy pillars of SB 184 was the legislature's recognition that moving California toward value-based payment is itself an affordability strategy. However, unlike the total cost of care metric, which bases accountability on organizational performance for cost and quality, THCE attributes spending in the healthcare system to physician organizations for which they have no control. Given that, the potential for a risk-bearing organization with excellent performance under the TCC metric to end up above the cost target is more likely. In many respects, California's risk-bearing physician organizations were bending the cost curve long before OCA established statewide cost growth targets. As APG explained in its recent comment letter, these organizations have already invested in the infrastructure that OCA hopes to encourage throughout the healthcare system, including population health management, utilization management, care coordination, quality improvement, and total cost of care measurement and transparency programs. Our concern is that the draft enforcement framework does not distinguish between organizations that have already adopted these value-based accountability models and those that continue to operate under fee-for-service reimbursement. The enforcement framework as currently drafted is essentially payment model neutral. It treats organizations that have voluntarily accepted land level 4 financial accountability for affordability the same as organizations whose reimbursement continues to reward utilization. Given that factors such as hospital rates, drug costs, and behavioral healthcare spending lead to potential enforcement under this draft regulation, it's only fair to consider what factors the organization has under its actual control in the enforcement or PIP process. APG respectfully suggests that the final regulation recognize participation in a bona fide value-based payment arrangement as a mitigating factor when OCA determines whether a PIP or penalty is appropriate and how the plan should be structured.
2 minutes.
Organizations that have already assumed meaningful financial accountability for TCC should receive credit for implementing the very affordability strategies that SB 184 was designed to encourage. Thank you.
Thank you. Looking virtually, seeing no hands raised, noting for the record, we have about 60 virtual attendees right now. We'll go back to the podium.
Beth Capel, Health Access, California. We want to say again that we support commensurate penalties consistent with the California law, and we oppose, as some have suggested, using the laws that apply to other states like Oregon and Massachusetts that have very modest penalties or none at all. And that we support limiting the penalty justification factors to those enumerated in California law, including, and we appreciate Joan Allen's comments, the fiscal condition of the entity as part of a system, as well as any subsidiaries or affiliates consistent with the law, and the market impact of the entity looked at by market segment. And we oppose use of penalty justification factors not enumerated in California law. We also oppose double counting of enforcement considerations at the penalty justification phase. And so it is right that if fertility coverage costs 0.2%, not 2%, 0.2%, that should be considered, but it should not be considered twice. It should only count once. And so we will look forward to further elucidation of the process. And with respect to the procedural penalties, we are, if you could go back 2 slides to slide 67, we are troubled by, well, that's not it either. We are troubled by the $500,000 flat penalty for failing to implement a performance improvement plan if by doing so the entity avoids the spending target penalty, which could be much far larger. So we just want to better understand the interaction of those two to assure that people aren't using the process to avoid penalties that they have earned. So, and we did not hear any of the discussion in that light, but that is the reason why we suggested looking to the commensurate penalty as the measure in the law. Thank you.
Thank you. Looking virtually, seeing no hands raised, looking to the podium. Seeing no one at the podium, I'll give it just a moment. This is also the general public comment period. Seeing no one at the podium and no hands raised, that concludes public comment on this item. And our next advisory committee meeting is October 14th in this building and room at 10 a.m. That concludes our meeting. Thank you all.